of the morning. For that, I'm inviting co-chair on the stage, Dr. Ketan Ranparia from Surat. Dr. Pooja Khosla may join afterward.
Good morning. Day 2, session 8, short communications and challenges. This little bit shuffling in the order. So first speaker will be Dr. Gopal Bora from Jodhpur, and he will speak on the interesting cases of OI in HIV. Gopal Bora is an additional professor, Department of Medicine, Nodal Officer, Jodhpur, and area of study is infectious disease, HIV.
Thank you so much. I am Dr. Gopal Bora. I am additional professor in AIMS Jodhpur. I would first like to thank Dr. Ishwar Kannada for inviting me and providing this opportunity. We have started DM infectious disease in AIMS Jodhpur. For last 2 years, we are running this course. I hope my presentation can be straight. So we will be discussing 2 cases of infectious, interesting cases of opportunistic infections in HIV. My first case. So it was a young male who presented with fever, dry cough, loose stools, some skin lesions, and weight loss. And the duration was 3 months. So with a short history of fever, dry cough, and loose motions, and weight loss. These were the skin lesions which we can see on the arm and forearm, on the lower limb. They were generalized, distributed all over the body. So when we examined this patient, we found that he also had oral thrush. We should note that we didn't have any previous history. We only had a history of fever for 3 months with cough, loose motions. So no previous history. On examination, there was thrush with multiple skin papules, few complicated lesions. Lymph nodes were enlarged in cervical, axillary, inguinal, all the lymph nodes were enlarged. Palpitations were heard on the right side with reduced air entry. This was the X-ray. So with this thing, 3 months history of fever, cough, loose motion in a patient, the differentials we were thinking of is whether this patient may have an immunocompromised state with disseminated mycobacterial disease based on lymph node enlargement, some endemic mycosis, umbilical lesions. We thought about molluscum, and there were lymph nodes. So a lymphoma was also kept as a differential. The initial investigations revealed that the patient was anemic, HIV status came positive. The inflammatory markers were raised. There was transaminitis and there was AG reversal. So we were right on the path of immunocompromised stage with a mycobacterial disease that was coming to our mind. Stool examination revealed some cysts, and we went for an imaging study of the neck, thorax, and abdomen, which confirmed that there were multiple enlarged necrotic nodes and right-sided duodenum with hepatosplenomegaly. So our direction was right towards a mycobacterial disease, most likely, and lymph nodes were enlarged, hepatosplenomegaly, necrotic nodes, AG reversal, inflammatory markers raised, 3 months history, weight loss history. So we were moving very comfortably towards a uh, and with that urinary lamp came positive. So and CBNet was also positive in the induced sputum and lymph node, and urinary histoplasma antigen also came positive. So the biopsy of the skin lesions also revealed intracellular yeast. CD4 count was very low. So this case made us to think about co-infection with TB and histoplasma. So TB and histoplasma co-infection is a diagnostic and treatment dilemma. Burden of histoplasmosis is less known, even not considered. If we had not gone for the urinary histoplasma antigen, this case would have been diagnosed, but the skin lesions definitely were a very significant pointers toward any other etiology. And the co-infection is frequent, though likely underestimated, and we should also investigate further. The traditional gold standard like histopath and culture are less sensitive, time consuming. So histoplasma, polycyclin antigen, which can be detected in both serum and urine samples with a very good sensitivity and specificity should be a thing that should be considered. And we can see that in the disseminated disease and in CNS, the antigen detection has a reasonable good sensitivity. So it is best for diagnosing disseminated and CNS histoplasmosis. There are then treatment issues regarding rifampicin and its interaction with itraconazole, ifavirenz, nevirapine, lopinavir. All these have issues with itraconazole. Fluoroquinolones can be used as an alternative agent to rifampicin if these issues are significant. But there are no clear-cut guidelines for treatment of histoplasma TB co-infection. I've already used my 5 minutes, so I will be straight away moving to the second case now. So the take-home message in this case was that histoplasma antigen should be frequently used, and we should not be stopping at just one infection in cases of immunocompromised patients, HIV. The second case was a comparatively older male with 6 months history. Now the history has extended. There are no comorbidities still, but the history is for 6 months with intermittent fever, cough, loose stools, and weight loss. And smoker, alcohol intake, and there were oral ulcers on examination which were suggestive of candidiasis. And there were few bilateral crepitations. There was pallor, and a respiratory examination suggested similarly the crepitations with reduced chest wall movements. There was mild anemia, PLC was slightly raised, inflammatory markers were raised, and HIV came positive. Now this patient has bilateral heterogeneous opacities. So we were thinking of tuberculosis naturally, 6 months history, with fever, intermittent, with cough, with weight loss, and bilateral heterogeneous opacity. So tuberculosis in a patient of HIV is one thing. PCP pneumonia, fungal pneumonia that we have already discussed, everything comes to our mind. We had other investigations which we sent, we couldn't find anything in like sputum KOH, and there was in sputum aerobic culture sensitivity pseudomonas group, which was trans sensitive. Cultures were negative otherwise. So we screened for opportunistic infections. Here also the sputum CBNet was not positive. In that case, sputum CBNet was positive. In this case, it was not positive, but urinary lamp came to be positive. So CD4 count was 82 and viral loads were on high side. Then we also went for CCT, thorax and abdomen. in which we found multiple areas of consolidation with necrotic areas, cavitations, regions, and bronchoscopy was also done. No malignant cells, ZN staining, no AFP, no KOF. But the modified ZN staining was also done, looking at this in this case for the opportunistic infections. And thin filamentous branching AFPs were seen, which were suggestive of nocardia species. So, based on urinary lamp, we may have been thinking of tuberculosis, but there were these chalky white adherent colonies identified as nocardia rotating sclerum by Malditoff. And so, nocardia should be considered in HIV patients. It is a rare opportunistic infection with a high risk in CD4 count less than 100. The diagnosis may be significantly delayed, and it is important to identify the species. Usually, the species are not identified, only the microbiology people many times say it is nocardia, but it is important to identify the species because the sensitivity is very important, very different in this. You can see that here. Imipenem and ceftriaxone, which are two major drugs which are used in nocardia treatment, this nocardia rotated sclerum is resistant to both of them. So the treatment will be significantly different. Initial treatment is with the, we already know how the initial treatment is. The treatment is prolonged. For pulmonary, it is 6 to 12 months. And for skin infections, it may be less. So, if we evaluate the contribution, there was a study in Ghana which shows that it is in 16% HIV and nocardia may coexist. The figures may vary in India, but we must understand that urinary alarm is an important point of care. Test can be easily done for diagnosis of HIV associated tuberculosis, especially in those with CD4 counts of less than 200. But we should be considering that there may be false positive findings. The WHO recommends that the lab should be done in patients with TB with advanced HIV disease, CD4 count less than 200. There are strong recommendations, but there can be false positive urinary alarm when the sample is contaminated with other bacteria or actinobacteria like nocardia. So here, so we can see that our patient had nocardia and urinary alarm was positive. If we would have stopped there, not gone for the modified stain, we would not have diagnosed and properly treated. So it is very important that we treat them just a minute more. And we treated this patient with the sensitive drugs and had very good results. The patient was asked for monthly follow-up and continuation of treatment for 12 months. And the patient is with us for last 6 months. Thank you so much.
Thank you very much, sir, for the interesting case and also congratulating times. We will conduct mission on the session at the end of the session. Thank you very much. Our next speaker is Dr. Neha Rastogi, following ground. He will deliver a talk on HIV in immunocompromised. He is a consultant infectious disease specialist and associated with the Fortis.
Thank you, everyone. Good morning. So HIV and immunocompromise itself is a very double trouble kind of a topic because HIV itself is a very immunocompromised disease. And when we talk about in the terms of immunocompromised, we have the varied presentations. HIV with malignancies, we all know we have a typical AIDS defining malignancies and even non-AIDS defining. Transplants in HIV. The ball game has shifted now to the different side that transplants are now considered to be one of the game changers in HIV. But yes, it's a difficult task to manage the SOTs as well as the HSCTs in the HIV patient, be it an autologous or an allogenic. And last but not the least is the autoimmune disorders in the HIV. So just to go through, we have a case that there is a 32-year-old man who was diagnosed with HIV 5 years back. The last CD4 counts were of 84 and the load was 55,000 plus copies. He developed a tonic-clonic seizures and which lasted for several minutes. There is no history of head trauma, no gallbladder incontinence, no recent febrile illness. He had just a past history of Staph aureus pneumonia. At presentations, these were the vitals which are more or less hemodynamically stable. There was a local examination of eyes, head, oropharynx, nose as such abnormality. And neurologically also there was no focal neurodeficit as such except the seizure history was there. He's on the HIV therapy, ART therapy, TLD based regimen with Septran and Cotan prophylaxis. So if you see his MRI, I have shown the important findings in both right and left side. So on the left side, you can see a ring enhancing lesions where there are some eccentric and a very shady borders outlined. And on the right side, you can see those hyperintense lesions with a very large hyperintense vasogenic edema. The perilesional edema was very quite strong. So based on this, because every time when we see an HIV with this kind of ring enhancing lesion, of course, we are sitting in India, the first thought goes to our mind is it a tuberculoma? Second, of course, we have a more little training and more expertise in HIV. We go further beyond. We think about cryptococomas or maybe toxoplasma. Eventually, there was a discrete mass lesion, as I have shown, and there was an increased rim of enhancement as well. So the CSF was done. There was a heavy cells, and of course, apart from all the infectious workup being negative, malignant cytology came out to be positive. So the brain biopsy was also done simultaneously, which showed that there was a dysplasia, there were the diffusely infiltrating cells with the larger nuclei, and CD20 positive in their patterns. IHC EBV was very strongly positive, and hence this was a diagnosed case of primary CNS lymphoma, which is a subset of B-cell lymphomas NHL, positive with EBV in an HIV patient. So as I mentioned earlier, AIDS defining malignancies can be there, which is Kaposi's, primary CNS lymphoma, part of NHLs in itself. Burkitt's is also one very important differentials when we think about it. And a cervical cancer now being added onto the list. Non-AIDS can be the multiple based on the different solid organ involvements as well as the Hodgkin's amongst the hematopoietic stem cell transplant. Haven't mentioned about the leukemias, which are otherwise sporadically associated with the HIV patients. As far as the HIV malignancy is being considered, we need to understand two things. A, the persistent chronic inflammation per se the HIV is causing, and the continuous Th1 and Treg stimulation, which can induce the state of the dysplasia. Second is the associated oncogenic viruses history. So for example, in this case, if you see the primary CNS lymphomas have almost been associated totally with the EBV virus being there. So we need to understand that whenever we are thinking in terms of a longer term HIV patients, these kind of differentials have to be kept upfront in the mind as the based on their more subtle presentation, and rather I should say a little temporally correlated. So what are the difficulties in management of these cases? We got the diagnosis. A, is it an AIDS defining malignancy? Because of course it's an important surrogate marker that which stage the patient is in now. What is the timing of initiation of chemotherapy? And one that say that the chemotherapy being initiated, the counts are anyways going to be falling. So eventually it will be more difficult to manage both the OIs, the HIV therapy per se, and what about the CD4 markers and all? Because once your counts are low, it's very difficult to pick up the CD4 as one of the standard criteria. Very important point is the drug-drug interactions, which we eventually see and observe on daily basis. How to monitor the response of treatment given the cell counts will be affected by the chemotherapies. What is the risk of iris? Because with so much immune interplay being going on, what is the risk of iris in such cases? What kind of OI prophylaxis? And of course, the very important question, the prognostic and the performance scores eventually. Because one day or the other, these kind of malignancies may will go towards the transplant cases as well. So one important dictum is that all patients should be treated with chemotherapy irrespective of HIV status, of course, provided they are being eligible for that except CLLs. And all patients should receive ARD irrespective of their cancer status. Like I mentioned, major concerns are drug interactions and side effects. CD4 counts can decrease during the chemotherapy. So the prophylaxis of your opportunistic infection should be always upfront in the list. Granulocyte clonally stimulating agents and antibiotic prophylaxis is another important domain to be answered because GCSF stimulates and also sometimes becomes counterproductive in terms of the HIV therapy. But it is a need of an hour. Whenever desperately needed, you have to resort to these measures. So the overall outcomes being defined by older age and diagnosis. What kind of lymphoma are we treating with? So mostly the aggressive histological subtypes are linked with the very higher mortality rates, low CD4 counts at the baseline of the diagnosis, and of course the higher HIV viral load, because the increase of the chemotherapy further breaks down the immune system to a level. However, having said that, there is an overall survival in the positive cases on ART, which is statistically similar to the HIV seronegative patients as well. Now coming to the another section is the hematopoietic stem cell transplant and HIV. So this is just about the brief evidences I'm just going to highlight in the interest of the time. So there has been the meta-analysis and systematic review about the different kind of bone marrow transplants being considered in the presence of the HIV. So this list talks about the various multicentric studies which have incorporated the autologous transplant. And good part is that the median disease-free progression as far as the whole lapse rates are very, very less, and the disease-free progression survival is very good. And the transplant-related mortalities are also less as far as the autologous transplants are being considered. What are the determinants you need to find out? That which kind of transplant you are using, because we also understand that the allogenic or a high-risk transplant involves more chemotherapy, more profound immunosuppression, more increased conditioning regimen, and of course, then the post-transplant issues, something like the graft versus host disease, viral reactivations, and majorly the immune effects. Because these days at our centers, when we are doing it, we have HIV with the transplant cohort patients, and we have been seeing there is not many times the iris kind of a thing arises, both in terms of the transplant and the HIV itself. Talking about the SOT in HIV also, so this is a beautiful review of systematic review in the kidney transplant outcomes in the HIV positive patients. So they have taken more than 1,500 plus case series of retropositive being gone for the solid organ transplant for kidneys. And at the 1 year rate, the patient survival was almost 0.97, which is a very good, with the graft survival of 0.1, 0.91, and only 40% patients had the infection rate, though it's not a small number, but they were manageable infection rates, with majority being the viral reactivations. What are important is you should have a proper pre-transplant, peri-transplant, and post-transplant monitoring. And with the hope guidelines these days to come, we have also seen the HIV positive donors giving the kidneys to the HIV negative recipients. And with the appropriate ATG conditioning, you can actually get the donor being positive outcome in the recipient. About the liver transplant, just to touch upon, this is another meta-analysis which have shown in the longer term outcomes in the liver transplant patients, majority of them were the disease donors, and the 80 plus HIV positive versus the 440 HIV negative, there was the patient survival was almost equivalent in both the groups, and diagnosis of HIV per se was not statistically significant predictor, which gives a very good hopes and the future potentials in terms of the HIV. So our center experience, if I share in last 2.5 years, we have running 4 patients of HIV with lymphomas, 2 with ALL, 4 with AML, of which 2 have relapsed. One is the primary T-cell cutaneous lymphoma who has just been admitted with the CMV retinitis and 168,000 plus copies of CMV viremia, all going with the alemtuzumab based treatment. So the idea is that the therapy plus drug interactions plus OI, we need to manage it all together. And then eventually the solid organs and the liver transplant are also rising in the number. Last but not the least, a word upon the autoimmune disorders. See, with the HIV infection and the autoimmune pathogenesis of T cell and B cell dysregulation with the molecular mimicry to lot many important antigens on the surface, there has been an increase in the autoimmune disorders, specifically rising from the SLEs. We have been seeing Kikuchi, Kimura, which are recurring into the SLE after the median time period of the 6 months. So these things and these differentials also have to be kept in mind apart from infection. So one very important dictum is all OIs or all kind of fevers or all kind of problems in HIV is not only related to the infectious complications. And this is a study period from the Taiwan of the period of 12 years, and they have found out that the amongst the lot of 20 plus HIV positive patients for PLWHA, there has been a higher incidence of the autoimmune, specifically in terms of Sjogren's, SLE, and the AIHA, which do require steroids, which is another an important area of research in the HIV patients in the presence of the viral multiplication to halt upon. So what are the futures ahead is? Need to have a more stringent precision-based medicine when we are talking lot of HIV in the next couple of day and eventually the next year also, that how we can more easily and more accurately detect the cancers upfront, which defines the AIDS-related malignancies. How we can decide upon the remission, because the cancer detection and cancer remission also becomes a very important determinant to eventually follow up. How about to decide about the chemotherapy patients? transplant. And now that India has entered into the new phase of CAR T cell based therapies in the terms of the cancers and BNTs, another areas and domains are rising up with the co-infections with the HIV. And last but not the least, with so many molecular antibodies or MABs and immunotherapies and biotherapies of cancers, the discussion about the opportunistic infection in their timelines also becomes very important. So thank you all for the patient listening.
Thank you, ma'am. And within a very short period of time, 10 minutes, you have covered almost all aspects that are the problems in the management and solutions related to the HIV compromise. Thank you very much. Our next speaker is Dr. Harsh Toshniwal from Ahmedabad, and topic is HIV with red eyes. He is a chief infectious consultant at Ahmedabad.
Outset, and thank you to organizers for giving me this great opportunity to present the case of HIV with red eyes. It's an important case for residents and postgraduate students and those who have started practice in the past. A 33-year-old male manager in an ice cream firm from Ahmedabad presented to us on 29th of July 2022 with the complaints of decreased appetite and weight loss of 9 kg since 6 months. He complained of pain and redness in both eyes since last 2 months. There was no complaint of fever, joint pain, skin rashes, other cardiovascular, respiratory, GI, GU symptoms. There was no past history of tuberculosis, any surgery, blood transfusion, diabetes, or hypertension. On examination, his vitals were normal, but oral cavity was showing a severe thrush. Eyes were showing mild redness in both the eyes, and he was complaining of pain. Rest of the general examination and systemic examination were unremarkable. Prior coming to us 2 weeks before, he had consulted an ophthalmologist for his eye problem, and clinical diagnosis was kept as a bilateral anterior uveitis. Oral prednisolone was started 60 milligram per day for 7 days, and that was reduced to 50 milligram for next 7 days. So he had completed 2 months, 2 weeks of prednisolone, high dose. There was no evident benefit after 2 weeks of treatment, and hence he was advised to consult a physician to rule out a systemic cause of the uveitis. Now, all you know, coming to the literature, systemic causes of uveitis ranging from infectious, non-infectious causes and drugs. And infections very common we find is a TB in India, syphilis, toxoplasma, and viral infection ranging from HSV, VZV, Ebola, CMV, even COVID virus. We have seen a lot of red eyes. Systemic inflammatory disease is ranging from spondyloarthropathy to psoriatic arthritis to SLE and Sjogren, everything. All these diseases can cause red eye and uveitis. Very interestingly, it has been observed that when it's used for a longer period of fluoroquinolones, particularly to treat MDR-TB, the levofloxacin long use can cause anterior and posterior uveitis. Other drugs are targeting immunotherapeutic patients can also cause uveitis. Now, we will did the investigation, there was nothing much alarming. So RPS was a bit high, but HbA1c was marginally elevated. This was because he had consumed steroid for the last 2 weeks. SGPT was 173. Rest of the serum investigation this side were normal. It turned out to be HIV positive, and we tried out. We confirmed it was HIV1 reactive. His CD4 was less than 71. His total syphilis antibody was reactive. It was 2024, while cutoff was only 1. With this, total syphilis antibody was positive. Surprisingly, his rapid plasma reagent, that is non-triple test, turned out to be negative. So we could not understand why. XHS was normal. His USG abdomen and soft part were non-contributing. So when we interpret the syphilis test, first we have to understand what are the triple tests, which are total syphilis antibody, which are being done by E, IA, or C, and IE recently. TPHA, and fluorescent treponemal antibody absorption test. Non-treponemal tests are VDRL and RPM. Most of the laboratories now perform RPR test only. And we also know the importance of these both kind of the tests and how to interpret the test of all these treponemal and non-treponemal interpretation of the test results, which are sometimes very complexing. Usually we go with the reverse algorithm. We do a treponemal test. If it is negative, we have to go for alternative diagnosis. If we very strongly suspect still syphilis, then you have to repeat the test of treponemal based test 4 weeks or 6 weeks apart. If treponemal test is positive, you go for the non-treponemal test. Non-treponemal test is important for 2 reasons. One, it will give you this and by and large staging of the disease, as well as it will monitor the therapeutic response that we have judged only from the non-treponemal title. If non-treponemal test is positive, you go directly to treat the disease as per the staging. And if it is negative, then again you repeat the treponemal test with a different antigen. The most important aspect is when your treponemal test is positive and your non-treponemal test is negative, what could be the different scenario? So it could be a latent syphilis where almost inflammation has burned out and you don't get a non-treponemal test positive. Second is when previously treated patient, as you know that all treated patient ultimately you will have the decreasing titer of non-treponemal test because that gives you a guideline to the monitoring of the treatment response. So sometimes when there is a non-existent non-treponemal serum level or titer, this can be negative, though patient has initially previously suffered from the syphilis. And third is the false positive treponemal test. Non-treponemal test is negative, treponemal test is positive, but it can be false positive. And most important, fourth scenario, which we have seen in our case, and that was the ozone phenomenon. So in our case, treponemal test was positive. There was red eye. It was strongly positive total syphilis antibody, but non-treponemal test that RPR was negative. We requested our lab to do the test with the dilution. And because excess of the antibody inhibits the inflammation reaction, and this inhibition is called ozone phenomenon. And we were surprised to see that RPR, which was negative initially, when in a routine dilution it was done, has turned out to be RPR positive in the dilution of 1 to 5 minute 12. So strong positive non-treponemal test. Natural history of syphilis, all we know about primary syphilis, secondary syphilis, early late and tertiary syphilis. But remember that neurosyphilis can happen anytime in the course of the illness. That is, in primary syphilis also, secondary syphilis also can be started, and late syphilis also. And neurosyphilis can also have the ocular syphilis and photosyphilis. Now coming to the ocular syphilis, because our patient had a red eyes and he had suffered from ocular syphilis, the ocular complication may occur as a part of neurosyphilis, or it can occur as an isolated manifestation of syphilis. Anterior and posterior uveitis or tan uveitis, the most common presentation. It can happen in early neurosyphilis as well as not late syphilis also. The other than uveitis, patient can have the episcleritis, vitritis, retinitis, retinal enamel, retinal detachment, and retinal necrosis, interstitial keratitis, optic atrophy, also in different stages of disease. When you manage the syphilis, what is the most important is the pre-management, pre-treatment evaluation. You should have the baseline non-treponemal titer because that will monitor the ultimately the response to the treatment. You should also find out what is the clinical stage, early or late, because treatment differs. And you must also find out if patient is allergic to penicillin or not. These are essential 3 points. Indication of CSF evaluation is neurologic signs and symptoms with positive serology of syphilis. When there is a treatment failure for syphilis, when there is a relapse after completing the treatment and patient has responded well, or when patient is co-infected with HIV, the CD4 is less than 340, and or the non-treponemal titer is RPR titer is more than 1 to 34. Our case, when did the CSF, the cells were 20, protein was marginally high, and VDRL came out positive 1:1 ratio. Coming to syphilis treatment, again, literature, early syphilis used to be treated with single dose of benzathine penicillin, 2.4 million unit. If patient is sensitive to penicillin, the alternative drugs are ceftriaxone or doxycycline for 14 days. Late syphilis, the treatment is 10.4 million unit of benzathine penicillin, but weekly interval for 3 weeks, which we are doing most of the time because we cannot differentiate many occasions from early syphilis to late syphilis, from late syphilis. So they are again treatment remains same, but it is weekly injection for 3 weeks, benzathine penicillin 2.2 units. If patient is sensitive, again you go for the same ceftriaxone or doxycycline for 10 to 14 days. Importance is that when you diagnose neurosyphilis or ocular syphilis, your treatment would be aqueous crystalline penicillin, 3 to 4 million units every 4 hours for, I say, 14 days, not 10, but 14 days should be given. And cannot go for the alternative medicine, but this is that if patient is sensitive, you go for desensitization and then complete your therapy for 14 days in the same manner. Now coming back to our case, we stopped prednisolone, which was started by ophthalmologist. Intradermal test was sensitive test was done for penicillin, and there was no allergy detected. We started with aqueous crystalline penicillin 3 million units 4 hourly. First dose was given at 6 p.m. in the evening. He developed skin rashes after 3 hours. Anti-stomach was given and it was manageable. Second dose was given after 4 hours at 10 p.m. After 1 hour, there was high grade of fever with eyes, generalized skin rash, severe redness, severe pain in both eyes, and it was very toxic. You can see the eyes that become cherry red at that time and skin rashes reappeared. What happened? Was it a penicillin reaction and skin cancer did not reveal it, or progression of syphilis occurred, reaction to any other drug? We treated with an antidote and also with a co-administered, or something else was happened. And as it has been mentioned in the literature, our patient had developed Jerry's Alzheimer's reaction. JHR is systemic reaction resembling bacterial sepsis. It starts 6 to 8 hours after initial treatment of syphilis, commonly seen while treating the secondary syphilis. It's because it is likely due to the cytokine storm caused by the abrupt release of lipoproteins through the killed and lying tetrasomas. The onset is very acute with the chills, myalgia, fever, headache, body ache, tachycardia, tachypnea, hypotension, and vasodilation. Symptoms they last for 12 to 24 hours, but very threatening. It can be prevented by aspirin giving in an anti-inflammatory dose for 12 to 24 hours. The role of steroid in such cases is limited. In our case, we continued crystalline penicillin, aqueous crystalline penicillin after pre-medication with the phenamide and paracetamol injectable. Single dose of IV hydrocortisone 50 milligram was given. It is controversial, but we were very apprehensive, so we started them. And following that, we continued crystalline penicillin. There was no further reaction. There was significant improvement noted after third day onwards. We completed 14 days of course of IV crystalline penicillin. SGPT now decreased to 56. ART was started from 15th day of this initial of treatment, and at 3 months interval, we did RPR test, and the RPR titer came to 1 to 32, which was prior to therapy was 1 to 512. Monitoring of these kind of the cases we always done with the non-treponema RPR titer. Adequate treatment response is said when 4-fold decrease in the non-treponema titer occurs there at the 12 months, because the titer decrease that trend is very slow, and it may take 6 months to 12 months, but in certain situations 24 months. Frequency of monitoring of non-treponemal titer in HIV negative should be done in early syphilis 6 months and 12 months interval. Late syphilis should be done 6 months, 12 months, and 24 months to see the titer response. And HIV positive should be done every 3 months for first year and every year to look for the relapse. Thank you very much. The case was taken in way that is an increasing incidence of prevalence of syphilis we are seeing in the community, particularly our country. Both HIV and syphilis, bidirectionally increase the chances of each other. And these are the occurrences not very common, but this can be kept in mind by the neurophysicians or ID specialists. Thank you very much.
Thank you very much for very simple presentations and very useful, and must be clear to many doubts of the many doctors. Thank you, sir. Our next talker, not next speaker is Dr. Alexander. He is going to speak on prevention of violence against healthcare professionals.
Good morning. You must be wondering why prevention of violence against healthcare professionals at an AIDS conference. There are two reasons for this. The first reason is that there are certain issues in medicine which cut across all specialties, and violence against healthcare professionals is one of those. The second reason is that at this AIDS conference, we've been talking, catering, discussing, debating about the mental well-being and physical well-being of special populations. And I think doctors and healthcare professionals are a special population. And their mental and well-being and physical well-being is very important and needs to be catered to if they are to do the best they can for their patients. Hence this topic. The art of medicine has been practiced for several centuries in our country. In the past, it was a very revered profession. It was considered to be a noble profession. But in recent times, there have been a lot of attacks on doctors and healthcare professionals. The first picture on this slide shows a depressed fracture of the frontal bone of the skull of a junior doctor in Bengal. He had to be operated. Along with him, another colleague also received fractures to his ribs and spine. The second picture shows you the image of a doctor who committed suicide in Dasa, Rajasthan, exactly 1 year ago. She was fearing arrest for premeditated murder because she lost a pregnant woman to massive postpartum hemorrhage. And in spite of the best efforts of her and her husband, the patient died. She, being very apprehensive about arrest and humiliation, committed suicide. The third was a case in Bangalore, where a doctor and nurse were injured in the ICU because the patient died of COVID-19. And in the fourth picture, you see a young orthopedic surgeon who lost vision in the left eye due to an attack by a patient's relative. The World Health Organization has defined violence against healthcare personnel as an international emergency that undermines the very foundation of health systems and impacts critically on patients' health. Violence is also the intentional use of power, threatened or actual, against another person or against the group in work-related circumstances that either results in or has a high degree of likelihood of resulting in injury, death, psychological harm, maldevelopment, or deprivation. No physician, however conscientious or careful, can tell what day or hour he may become the object of some undeserved attack, malicious accusation, blackmail, or suit for damages. According to the Indian Medical Association, over 75% of doctors have faced violence at work, mostly as verbal abuse or as aggressive gestures. 12% of cases of violence have led to physical attacks on the doctors. 70% of the violence has been caused by relatives of patients. Nurses quite often bear the brunt, which goes unreported. Most violence occurs in emergency care, ICU, and OB/GYN departments. India has a rate of 3 violence against healthcare worker incidents per 10,000 healthcare workers. This is 5 times greater than the global rate. Among South Asian countries, India has the second most number of incidents and second highest rate after Afghanistan, which is considered a conflict zone. The violence against healthcare workers incidence rate in India was 57 times greater than in the UK and 850 times greater than in China. Both these countries have taken legal action against violence. Nepal has a much lower rate, less than one incident per 10,000 healthcare workers compared to India, yet it recently passed the Ordinance for Protection of Healthcare Workers. What are some of the reasons for violence against healthcare professionals? One of the main reasons is poor communication skills. We are not taught communication skills as medical students, and we learn how to communicate as we grow in the medical field. Lack of emergency resources, especially in the government sector. You have a patient who's very sick and there may be no blood, or there may be a delay in the results coming from the lab, or there may be the relevant drugs are not available. The emergency intake capacity is overwhelmed, so the patient and relatives have to wait. There may be a very high load of workload for the doctors with lack of staff. All of these would contribute to violence against healthcare professionals. Some other reasons are increasing education, intolerance, fearlessness against rule of law, and restlessness among the youth. Mistaken public belief that hospitals should give its services free or almost free. Unrestricted public access to all areas in the hospital with overcrowding. Lack of security, surveillance, and mob preventing drills in the hospital, and lack of civic responsibility in the public. Some other reasons would be absence of legislation and a reluctance of its application against a strong law against violence towards healthcare workers. Negative image of doctors portrayed in the media, political interference, and the establishment of the National Consumer Disputes Redressal Commission, also known as the Consumer Protection Act, and the medical service came into this act in 1986. Then again, as I mentioned before, inadequate communication. Some hospitals may have unethical practices and there may be lack of self-regulation. There may be a very poor grievance redressal mechanism, and the hospital leadership itself may not be aware of legal and regulatory mechanisms. Possible solutions. One is to remove the medical service from the ambit of the Consumer Protection Act. Not easily done, but that could be one of the policy changes. And if there are criminal cases against doctors, then the courts need to fast track these cases instead of going on for years and years and years. There should be a central act for prevention of violence against healthcare workers. And they are sought to be made right now. It is not a central act, it's a state subject. And assault to be made non-bailable in all states. Presently, only 25 states have non-bailable offense for assault on doctors. In 2020, India enforced the Epidemic Diseases Amendment Act, which recognized any violence against healthcare personnel as cognizable and non-bailable. But once the pandemic is over, this act can be dissolved. The Ministry of Health and Family Welfare proposed a central bill titled the Healthcare Service Personnel and Clinical Establishments Act 2019, with a clear definition of violence against healthcare personnel, health workplace, and health workforce, which is ill-defined in the Epidemic Diseases Act. This bill proposes imprisonment for varying periods of time and fines of varying amount. Most importantly, the bill was framed and finalized through democratic engagement, seeking public suggestions, and has greater societal responsibility, acceptability. However, it was rejected by the Ministry of Health, Home Affairs, stating that the bill would set an improper precedent for other fraternities to demand exclusive protections based on their profession. Some other possible solutions. Internal self-regulation in hospitals. You should have regular program audits and financial audits so you can look at the quality of care, the cost of care, whether ethical practices are being practiced, whether there is transparency. There should be a grievance redressal committee in the hospital itself so that a patient or relatives can go and address these issues before it escalates. And the hospital's public relations department should have a ear to the ground, should be able to anticipate if any violence is going to occur and be able to prevent it before it becomes worse. Communication has always been an important component of the healthcare work, and this was found to be lacking. There was inadequate communication in the hospital setting, and this could be one of the causes, or is one of the causes for violence. So way back in 2012, one of the hospitals brought out a book called Communicate, Care, Cure, which talks about communication. And each chapter is preceded by a true story, and then it's followed by how to overcome that lack of communication. And it's not only about communication between the doctor and the patient, but also between all the stakeholders in the hospital setting. This book did very well and is now into its third edition. And that instigated a kind of communication movement where doctors were trained as master trainers to provide communication skills. They went ahead and trained other healthcare workers. And in fact, there was a counselor who actually resigned her job and started an organization just to teach communication skills to healthcare workers. And more than 50,000 healthcare workers have completed the course. The Health Sector Skill Council is also starting an online communication course, which doctors can easily access, healthcare workers can easily access, and they receive a certificate at the end of that training. Now, with lobbying with the government and the National Medical Commission, communication skills has now been introduced into the MBBS curriculum. It is also a standard for NABH accreditation now. Externally, it's important for the hospital to be in touch with the local community, with lay leaders, with medical authorities in the area, with medical associations. They should all be in touch with each other, help each other when required. You should be aware of the local police station, be friendly with the constable and the sub-inspector of police. Maybe give them a free health checkup once in a way so that they are available when you need them. The judges sometimes are not aware about how the medical system runs. So to meet them at social interaction, maybe you could just sensitize them to these issues. And media, of course, is another thing that needs to be sensitized. What are the possible solutions for media? Networking with them, report positive stories, showcase good work, help in building positive public perception, supervision of the media by regulatory authorities, trial by media to be discouraged and penalized. Preventive strategies on the ground, be alert, maybe start a helpline for patients, effective surveillance with CCTV, etc. Restrict the number of visitors, especially after duty hours, appropriate signages, communication system within the hospital should be effective. If an incident occurs, remain calm, ask the colleague or hospital staff to accompany the person, announce code violet 3 times. Hospital's quick response team should reach the spot as soon as possible. The victim should be protected, moved away, and supported. Inform the jurisdictional police station and neighboring group of healthcare institutions and friends of hospitals. Follow up at the police station. Please remember that if a FIR is filed in a police station, a doctor cannot be arrested unless that case is reviewed by an expert or a group of experts. And if they feel that there is a case here, then only can an FIR be filed at the police station. Follow-up at court is very poor, both from the hospital and the aggrieved party, and it takes ages for the cases to be settled. The hospital should do a root cause analysis and try and resolve the situation and take corrective measures if the hospital was at fault. And of course, there should be counseling and support to the victim. The Association of Healthcare Providers of India, which has about 20,000 hospitals under its membership, and Indian Medical Association, which has got about 3 lakh individual doctors registered, joined together and brought out a book called Perils in Practice, the Prevention of Violence Against Healthcare Professionals. This book is useful. The foreword was given by the retired Chief Justice of the Supreme Court, Justice Venkatachalaya. Many well-known people have written in this book. Police have written, lawyers have written, judges have written. There's a chapter on communication. It is a very useful resource to have. And this book is dedicated to Archana Sharma, the doctor who committed suicide. And in her suicide note, she had said, if my death causes any action to be taken so that innocent doctors like us are not penalized unnecessarily. This book is available free, can be downloaded, and also on Amazon. It's 175 rupees for the copy. A core committee needs to be formed. They need to engage with all healthcare stakeholders at state, national level, collate all suggestions into a white paper, and implement suggestions over a given timeline. Downside of violence, psychological trauma to healthcare work hindering performance. Clinics, hospitals may shut down, leading to non-availability of healthcare. Defensive practices raising up the cost and discourages students from taking up the medical profession. The ultimate loss is to the community. Violence against healthcare workers is an urgent problem requiring attention from all societal stakeholders. It is not just a medical fraternity issue. It weakens the health system and affects the quality of service provided to patients, in turn, leading to more chances of violence. The key to breaking away from this vicious cycle is pushing for immediate zero tolerance policies. Let us try to bring back that sacred relationship between the patient and the healthcare worker. Thank you.
Thank you very much. Ma'am. Very, very nice. We will complete a very important topic. Thank you. Our next speaker is Dr. Sajid Kumar. He will going to speak on same-day ART. Is it possible in India?
Respected Chairperson, dear colleagues, friends. The title that has been given to me, can I have the slides? Thank you. The title that has been given to me is Same-Day ART Initiation, Is It Possible? We are all people who are practicing antiretroviral therapy for the benefit of our patients. Maybe from the olden days, when Zidovudin itself was not freely available, we asked our patients to wait for something to happen. And then we had the antiretroviral therapy. We asked our patients to wait again till they became sick. Then we did the CD4 counts and started treatments. And then we had the test or treat all policy. And now I think almost the ultimate in HIV management has come, which is actually the same-day ART initiation, which has got different names in different contexts. But put in simple terms, it means acceptance of ART on the same day of HIV diagnosis and returning to home with prescribed medication on the first day, whatever be the lines, whatever be the regimen that you're using. Now, at this stage, let me ask, how many of us sitting here are ready to start ART initiation on the first day? Can you please raise your hands? This is not a call, this is not a debate, but and in fact, this has come into the national guidelines, but still I see so many hands refusing to come on. Long-term benefits from early antiretroviral therapy has been documented right from the START trial we started in 2015, and the final conclusions of this has come up in 2021, which definitely shows that there is a benefit to immediate treatment compared to the deferred treatment in all aspects regarding survival, regarding events that happen, regarding the non-AIDS specific events that happen and all these things. And it has also demonstrated that there is a persistent diminished excess risk of serious clinical disease and lower immune recovery from different treatments. Delays in ART result in all those complications associated with that. And therefore, WHO had put this definition of starting treatment in 7 days of diagnosis, strongly recommending ART initiation on the first day itself, after ensuring the patient's willingness and readiness to start ART immediately, unless there are clinical reasons to delay treatment. As this has been practiced, there have been lots of reports coming from different parts of the world. And this particular report, which has come from Western Ethiopia, says prevalence of same-day ART initiation in that group among 483 study subjects was to the tune of 64.6%. Patients being started on antiretroviral therapy on the same day. And they analyzed what are the issues related to early initiation, and they found that it has 4-fold higher chance of same-day ART initiation among patients who are urban dwellers, 4 times higher among patients with opportunistic infections. There are so many positive effects. I don't have to highlight on this particular area of why and how we should start early ART. But let us also look at the reasons for delayed commencement, which includes patient's choice, prolonged adjustment periods, sometimes staff shortages, fear of drug side effects, younger age, and need to take time off work, and acquiring HIV through various routes like heterosexual contact, injecting drug use. These are all considered to be the predictors of delayed ART initiation. They studied different variables. the chance of delayed ART initiation is the odds of ART initiation early is delayed by 2 times in males. If they had a family member, it was much better. A family member who was HIV positive, having at least one other chronic disease, 3.7 times chance of starting the treatment. A substance abuse person has a 3.79 times of delayed ART initiation. And if the patient is ambulatory and having a functional status, there is 5 times chance that the treatment may be delayed. They have analyzed in detail why the treatment is delayed in majority of instances. They are also common with many of our patients. The women who are highly influenced by the physician's counseling than males, no gender discrimination intended. Females getting stronger counseling, education, and monitoring by healthcare providers during their antenatal checkups and maternal and child health services. Presence of comorbidities, which actually helps sometimes patients to choose the drugs. And the issue of treating both chronic diseases simultaneously can lead to unjustified fears, not only for the patients, but also for the healthcare workers. And HIV positive people with other HIV positive family members are likely to get better reinforcement and social support, and therefore they are also good candidates. Substance abusers experience cognitive impairment, which can hamper their decision-making abilities, and it can actually affect their rigorous adherence to ART therapy. Other than negative effects for a same-day ART, there have been a lot of reports which said that loss to follow-up after first day, after same-day ART is pretty high. 24.7% in late ART compared to 31.6% on same-day ART, and unfavorable outcome after 12 months was 28.9% of the same-day ART group compared to 21.2% on delayed ART. There are again lots of studies. I'm not going to the details of all those things, but most of them have said that response to therapy and other parameters are all equal when it comes to immediate ART or same-day ART. But there are a lot of concerns about patients, or by the patients, about expedited ART initiation. They are not given enough time to conceptualize the lifelong therapy, and there is the risk of immediate disengagement from care after treatment initiation. And there have been many reports where the patients under same-day ART never returning for a follow-up visit. Then different populations might behave differently. Counseling support is likely to be deprioritized in busy public sector settings, which is very common in our situation, where the insufficient adherence support is likely to be a major problem when we start treatment early. Well, fortunately, what is happening in India, national guidelines 2021 has already incorporated this, and this is just a photocopy of what is being given there. They have put out this particular terminology which says day 1 preferably initiate ART, preferably the same day if the patient is ready. ART to be dispensed for 1 month. Concurrently send the samples for CD4 count and other baseline investigations. Advanced HIV disease management, again, national guidelines are clear. It has also talked about rapid ART initiation in new cases and same day ART if possible. ART initiation should be offered on the same day to people who are ready to start. This is already there in the national guidelines. And people who have no clinical signs and symptoms of TB or other OIs and whose crack test is negative may be initiated on ART on the same day in combination with their package of prophylaxis. Of course, the issue about screening of these patients is significant, but most of our hospitals, most of our centers have this particular test which is available, which can be used for screening for TB. If the urine lamp test is not available, it's still not available in India for routine basis. So if it's going to be available, there is going to be a big boom for that. And there have been large number of studies on urine lipoarabinamide and detecting tuberculosis, which can actually help us in deciding whether the patient can be put on same-day treatment. So these are all about lipoarabinamide studies and sensitivity and related issues. In fact, this is actually an extract from the national guidelines, which speaks about the advantages of screening using NAT as well as TB lamp, and they have put the footnote very clearly that currently TB lamp assay is not available in the program. Now, WHO has recommended the use of LF lamp. All of us know about that. In fact, my previous speaker has also highlighted on this issue the situations where WHO has strongly recommended LF lamp to assist the diagnosis of active tuberculosis, patients in whom the signs and symptoms of TB who are inside advanced HIV disease or those who are seriously ill and CD4 count of less than 200 cells per cubic millimeter. Now, they have also suggested that if the patient comes in outpatient settings with signs and symptoms of TB, or if they are seriously ill, that is another situation where this can be useful. And now the issue about crack. Again, there is no doubt about that. This is a very important diagnostic tool. Yesterday also we have discussed in detail about the use of crack in screening for patients who are coming to us. And there have been so many reports speaking about the incidence of crack positivity among the general population, which is also needed. And in fact, there have been cost-effective studies related to this also, which speaks about the use of lab. And Indian studies are also there. High prevalence of cryptococcal anemia among asymptomatic advanced HIV patients in Pune. And this is another study from Eastern India, co-authored by our Guha sir, where the crack positivity was reported to be 12.56%. And it's quite possible that if you're able to do this, that is the best option available. So this is again from the national guidelines, which speaks about ask, look, and investigate for cryptococcal meningitis, where if the patient has got a low CD4 count or presenting with symptoms suggestive of cryptococcal meningitis, crack can be done. So that's all the positive things about same-day ART initiation. Now coming to the other issues, it has been noticed that whatever be the modality of treatment, whether it is same-day treatment or early antiretroviral therapy, after 24 months, the patients are going to have the same amount of viral suppression. And this is one abstract which has been presented from Thailand in the latest CROI, which talk about similar short-term outcomes with same-day ART initiation versus rapid ART initiation. They found that there was not significant difference between these two groups. Benefits and risks of rapid initiation of antiretroviral therapy. There has been a systematic review and meta-analysis, which suggested that the same-day ART significantly increased the treatment cost and loss to follow-up. The two treatment choices had a similar risk of adverse events with a viral load of less than 100 copies per ml at 12 months following treatment, and mortality, they were same. But of course, there is the additional benefit which we are likely to get from starting treatment as early as possible. The U=U benefit can be given to the patients as early as possible if we start treatment. The NACO stats, as was discussed yesterday, is talking about a big gap in people being introduced into treatment, initiated on ART, and patients who are going to be virally suppressed. So to reach the targets of 95, 95, 95 by 2025, probably same-day ART initiation and immediate ART initiation is going to be very, very helpful. And we also saw the last 2 days that self-testing, something which was probably kept away by India, has already been accepted. And now we have a direction for the same-day initiation from NACO itself. And the question is whether it is possible in India. That is the question that is posed. Is same-day ART initiation possible in India? May I ask people to raise their hands to see whether you are comfortable with the same-day ART initiation? Is it possible in India? It is possible in India. No doubt about that, because we have everything, almost everything free. The answer is a big yes, but there is another question. Is it essential? May not be. May not be, because of the various issues related to the hospitals, related to the healthcare workers, related to the patients, environment, supply, this and that. It may not be. So instead of the same day, we may opt for early initiation with a window of 7 days, which will give us a breathing time. But at the same time, the patient can go through the process of therapeutic counseling, the post-test counseling and other issues. And the tests, even though all of them are available and people say that they are all going to be cheap and accessible and all, in the current circumstances, they are likely to cause some delay in getting the results. So maybe same-day ART initiation is quite possible, but we will think whether it is essential or not. Thank you very much.
Thank you very much, sir, for explaining all the aspects that is very useful for all clinicians to make a call in day-to-day practice. Thank you very much. Now, audience can ask questions for all 5 speakers.
Yeah.
And please mention your questions to this speaker.
Yeah, I'm Raj Bhava from University of Miami. This is a question for Dr. Ruxpagi. It's a nice presentation.
This is just a suggestion. Use of steroids in CNS lymphoma. Before you make a diagnosis, do not use steroids. The steroids is a part of the CNS lymphoma treatment. So the caution I'm trying to say, when the patient comes in and having all these symptoms, have an X-ray of the head, there are some bumps, but to make a differential diagnosis, toxoplasmosis, Staphylococcus, tuberculosis, is it lymphoma? And if you use the steroids before you do a biopsy or a diagnosis, you are taking a partial treatment of lymphoma, and you may miss the diagnosis after 4 doses because after 4 doses they will do a good response. So be careful, physicians do not use steroids unless you make a diagnosis based on the biopsy.
Thank you, sir. And this will be the last question, please.
So my question is to Dr. Tushniwal. Sir, I'd like to know what is it necessary to stagger ART in cases of ocular or asymptomatic neurosyphilis? Can we start ART along with treatment for asymptomatic neurosyphilis or ocular syphilis? Or should we wait for 1 or 2 weeks? Like in your case, you said you started ART after 2 weeks.
We can start after once the disease becomes remission. After 3rd, 4th day, we could have started.
We need
There
not
are no guidelines
wait.
that.
Yes.
Basically, gate
Risk of iris, there is
no, then,
we don't.
yeah, we can start from 3rd day.
Thank you, sir.
Thank you. No, this is
First, because they want to ask others to this situation.
okay. But this question is something which cuts across. This is not a question, sir, really, it's a comment to Dr. Glory, who was speaking about the communication skills and other aspects. Now, NMC has actually introduced recently a new modality of training and communication skills, attitudes and ethics to the students, which covers about 146 hours during their 1.5 years of curriculum. And it is called the ETCOM module, Attitude, Ethics and Communication module, which speaks about so many case scenarios and other things. And the second issue, which is now happening with much more preponderance in Kerala, is the fact that even elderly doctors are being attacked. And so we cannot blame that the next generation communication is bad. So that is why all these things are happening. We had a person who was 64 years, a cardiologist, who was attacked and brutally. So there are so many other issues related to this, but we are trying in our UG curriculum to incorporate communication skills and attitudes in a big way.
All these 5 divergent topics have stimulated a lot of interest. I don't want to take too much time. But what really concerns several physicians here is violence against doctors. What fundamentally we should look at ourselves. Medical education you had alluded to. The problem is screening and assessment of patients who come with a life-threatening, organ-threatening, or limb-threatening condition is not existing in India. And therefore, people come with great anticipation to save a life, organ, or limb. And that is the problem. So that is why the National Medical Council Commission has forced all the 600 medical colleges to not depend on emergency services, but to create an emergency medicine department with a 30-bed with ICU. That to some extent look at the patient expectations. 85% of the people in my country die at homes. Only 15% die in the hospital, and they come late. And it is the guilt of the patient's families because they're coming late. And that is something that we have to handle.
I'm requesting co-chair to felicitate the faculty. Faculty, please come on the stage. Dr. Neha Mustafi from Gurgaon, Dr. Gopal Gora from Jodhpur, Dr. Harsh Toshniwal from Ahmedabad, Dr. Julia Alexander from Bangalore, Dr. Sanjit Kumar from Kottayam. Ms. Dr. Bazari sir, Felicity co-chair.
Now we will move on to our second session, which is HIV Manifest Beyond. I will invite the co-chairs, Dr. Bajare from Mumbai, Dr. Sanjay Kumar Matu, I will request the chair to invite the speaker.
Good morning, everyone. So we have half an hour, nearly half, almost for half 30 minutes in the future of the program. So I request all the speakers to keep their timing. And first speaker, Dr. Vijay from Hyderabad, is the belongs to University of Indonesia, Chicago University. And area of expertise transplant, infectious disease, immunocompetent host infections, inflammatory disorders, laboratory medicine, public health, and black belts. Your great task of covering all the neurological complications in 20 minutes. It's a great task. Thank you.
Thank you. Good morning. And don't want to cover everything because actually the previous speakers have done a wonderful job of covering a lot of very important topics in the central system in HIV, particularly syphilis, which is very common. So when we talk about the neurologic complications of HIV, we generally like to, what I'm looking at here is mainly a frontal approach, how you think about these things. There are peripheral syndromes and then there's a central syndrome. Does a person have a meningitis, or does a person have an encephalitis, or does a person have a neoplastic disorder? And then there is an entire other area of neurocognitive disorders, which are drug-induced, either the antiretrovirals themselves, ethanol, benzodiazepines, cocaine, and other substances of drug use. And then there are the direct neuropathic effects of HIV, which are inflammasome mediated. And this is an exciting area because the pharmaceutical industry is finally now focusing on coming up with small molecules to modulate the effect of inflammasomes in various areas. And then vascular diseases, neurodegeneration, which is like chorea and Parkinson's disease. So this is a very nice paper from India. And I always like to focus on the local scenario because this is where we are and this is where we practice. So if you look at the types of illnesses that we are seeing in the primary neurological, we are seeing distal symmetric polyneuropathies, almost 15% of the cases, Heights dementia complex, 6%, 7% of cases, acute inflammatory demyelinating polyneuropathy, about 3.5%, stroke syndromes. This, I think, will become a little bit more increased in frequency because our population is aging, and as they're aging, they're getting more trouble with illnesses that cause stroke and other. But when we start looking at the secondary causes, number one remains tuberculosis. And even in the era of COVID, I will tell you that tuberculosis remains a big problem in India. Tuberculosis remains, now that COVID has abated a little bit, the single largest infectious disease killer in the entire world. So everywhere, wherever you think something is going on, tuberculosis, something should be considered. Cryptococcal meningitis and cryptococcal illness. One of the big things about this is the realization and the evidence that is mounting that early screening for people with low CD4 counts with serum cryptococcal antigen is an opportunity to intervene earlier because the mortality of established cryptococcal disease, even with full treatment is around 30%. Toxoplasmosis. And yes, we continue to see, in fact, in the last 1 month, I saw a case of toxoplasmosis as an initial manifestation of HIV. So that's the first time HIV was diagnosed in that person. And progressive multifocal lupus encephalopathy caused by papilloma viruses and immunosupressed. So the other interesting thing here is how you think about the risk based on what the CD4 count is. Tuberculosis, remember, is a very virulent organism and will cause illness even with relatively well-preserved immune system. So you are likely to see tuberculosis at a higher CD4 count. Now, the national policy is to give everybody with HIV treatment for latent tuberculosis. So hopefully that will bring down the incidence of tuberculosis, central nervous system infections, but it will still remain a big problem. Cryptococcal meningitis, we start seeing as CD4 counts to below 100. And toxoplasmosis, again, once we see a CD4 count of less than 100. So really, all of these illnesses become far more common as CD4 drops below 100. Neurosyphilis, we can see at any CD4 count. And as we have just heard about this beautiful case of the red eye, and as protein manifestations, that is something that should be part and parcel of the differential diagnosis of anybody who comes in with any kind of illness with HIV, quite honestly. So distal symmetric polyneuropathy can also occur at clearly well-preserved CD4 counts, and pure HIV-associated dementia really has become rather uncommon in this era of heart. We used to see a lot of it in the pre-heart era, but now it's become very uncommon. One thing that I would like to emphasize here is it is abundantly clear, and there's lots of data from the 1980s that in people with HIV, we get accelerated neurocognitive decline if they are on benzodiazepines and other agents, and also alcohol. So there is a synergistic toxicity of the central nervous system with other agents when you have HIV. And then demyelinating polyneuropathy, again, can occur relatively because of CD4 counts. So what is the treatment outcome? Tuberculous bacterial meningitis, 25% die, even with effective treatment or so-called effective treatment. Cryptococcal meningitis, 40%. Toxoplasmosis, 15%. Neurosyphilis, 6%. EML, dismal prognosis. We do not have any agents specifically directed against papilloma viruses, and therefore even reconstituting the immune system has a dismal prognosis. So I'm not going to bore you about TB, Cryptococcus. I think that this is one area which is interesting because of the availability of the lateral flow assay to detect serum cryptococcal antigen. That's very, very good. Very sensitive, strongly encourage people who have a CD4 count of less than 100 to have a screening test. Obviously, it's a very good test to do in CSF before considering cryptococcal meningitis. And the interesting thing is the newer field array tests, which are made by human, also have the ability to detect both Cryptococcus uniformans as well as Cryptococcus gattii. So if you have the luxury of doing a very expensive test, you can get that. So, but one of the things that we should remember is to have a history of bird exposure, patient exposure, any kind of birds. We should be thinking about Cryptococcus uniformans. Occasionally, Cryptococcus uniformans will present as a pneumonitis, along with the meningitis. Can also present as a anemia. And this is one of the things that we should remember, that don't automatically jump to the conclusion that every yeast that is positive in the blood culture is Candida and therefore echinocandid will work. Remember, echinocandids have no activity against Cryptococcus uniformans. Okay, so we talked about this. This is an old test that we used to do. And I remember about 25 years ago, one of the microbiologists that I was working with was seeing it for the first time. He had no idea what he was looking at, and I had to come and say, okay, this is Cryptococcus uniformans. But Thank God we don't rely on this test anymore. We do the latent flow assay, which is very good. Toxoplasmosis. This is a problem. This is a very interesting story in medical ethics. In the early days of the HIV epidemic, we started seeing this brain lesions in young people, and we had no idea what it was. We really tried very hard to persuade the neurosurgeons to biopsy it. My colleagues were saying that you should know whether or not you're dealing with a lymphoma before you start giving steroids. Yeah, infectious disease people, we always like to know the diagnosis. We could not persuade the neurosurgeons to do any biopsies. I said, no, HIV, we don't touch the patient, it's going to die anyway, do whatever they please. So out of desperation, out of no other alternative, we started treating these people empirically with sulfur drugs for toxoplasmosis. And lo and behold, a lot of them got better. So now it became the standard of care that you don't biopsy these people, you give them treatment for 10 days, and if they don't improve, and there is other radiologic reasons to consider a differential diagnosis, then you will want to do a biopsy. Just an interesting example of bad medical ethics changing practice for the better. All right. So anyway, I mean, this is something that one should remember. The other thing that I would caution you is our radiologists are very fond of making diagnosis based on just imaging. A bad practice. I will tell you they are very often they are wrong. When we take the trouble to pursue a biopsy in a microbiologic diagnosis, we find that they are wrong. Right? So I think this is something that you should be alert to. That please do not go around accepting a neuroradiologist diagnosis as the ultimate. It is not. So these are, some lesions that we see in the brain. That's a episodes and toxoplasmosis. Now, one of the things that helps you is that on an MRI, if you see a solitary lesion with lots of mass effect, the probability that it's going to be a lymphoma goes up, the probability that it's going to be toxoplasmosis or tuberculosis goes down. Usually tuberculosis and toxoplasmosis lesions are multiple. This is just a rule of the hand, and you can take it to start initiation of therapy. But I think if you see a very large solitary lesion on an MR, you should be pushing for an earlier biopsy to exclude the possibility of lymphoma. Right. I won't bore you with all of this, but the bottom line is if you start seeing lesions in the brain that are quite extensive with an advanced immunodeficiency, the absence of mass effect and the absence of contrast enhancement strongly suggests PML. And unfortunately, the only treatment we have is trying to improve the immune system by HART. So this is progressive multifocal encephalopathy. So again, the other complications are dementia, neuropathy, vascular myelopathy, psychological conditions, lymphomas, and neurosyphilis we talked about. One of the things that I would like to leave you with is this idea that we should think about the NLRP3 inflammasome made famous by the COVID pandemic. This is a very interesting inflammasome because a lot of degenerative disorders of the central nervous system, including Parkinson's disease and other neurodegenerative disorders like Alzheimer's and also multiple sclerosis, some of them, the common pathway appears to be activation of this inflammasome called NLRP3. And in the future, we will have agents that block NLRP directly. Right now, we don't have direct blockers. We have some things like acalabrutinib that block it upstream. We have agents that block the effects downstream, like colchicine, but unfortunately, no direct blockers of NLRP3. NLRP3 is something that it appears to be the final common pathway of a lot of neurodegenerative disorders. So this is something for the future to think about. So that's all I have to say about the central nervous system complication of HIV. If we have enough time for others to say things. Thank you.
But the whole project is the complications And the big count of what are the common health complications, how they will represent, what is actually the study for function, and what actually we have to proceed to the Thank you very much. And we will take the questions at the end of the session. Next speaker is Dr. Ashwin Gogia. He's going to make a presentation of the cardiac complications for HIV. Welcome, Dr.
Very good morning. First of all, thanks for having me here. Thanks to the organizer, thanks to my chairs. Much has been discussed and a lot of nice presentations we've seen in the morning, but the part which probably has not been touched so far is the cardiac complications of HIV. So we have come a long way. These are the disclosures. So there is a whole spectrum of clinical entities which are there. So it is not possible to be covering each and everything, but yes, I would just briefly like to touch upon the common complications which one may come across in our day-to-day practice, some being very unusual and some which have become more common in the recent times because of the advent of better treatment. So we have a whole spectrum right from heart failure, asymptomatic LV dysfunction, cardiomyopathies, myocarditis, steatosis, pulmonary hypertension, infective endocarditis, coronary artery disease, and rarely, but still awareness to be there is cardiac neoplasms, which can be Kaposi's or the B-cell immunoblastic lymphoma. So what have we seen? That there has been a drastic decline. There has been a lot of discussion yesterday and how things have been implemented. So mortality has gone down because of highly effective ART. And because of that, a lot of complications which were seen in the pre-ART era are seen less often, but the risk of cardiovascular disease is increasing as there is longer survival. There is ongoing subclinical inflammation, as there was a talk also of rapid ART just before. So to kill the inflammation part, there are the traditional cardiovascular risk factors. And there is a lot of discussion about weight gain, metabolic syndrome as a part of complications of ART use and other ARTs, which cause an increased risk of cardiovascular disease. So that is how things have come up. So this was a study which was close to 10 years ago, in which they had non-HIV, HIV patients, 500 apiece, more than 500 patients, and they found that adults more than 45-year age had more age-related illnesses than the comparable adults without HIV. And HIV per se raised the chances of age-related illnesses by approximately 58%. So right from high blood pressure, heart attacks, peripheral arterial disease, kidney disease. So there is a substantially higher risk in the HIV subgroup as compared to the non-HIV subgroup. So heart failure has just picked up recently because of the updated guidelines in the management of heart failure, as well as a lot of new drugs which are available for heart failure management. And what we found is the heart failure is one of the most common cardiac complications, irrespective of what the underlying etiology is in the HIV patients. So if you see way back 2009, the impact of HIV infection on diastolic function and LV mass was studied, and what they found was that there was a 2.4 times greater risk of having diastolic dysfunction in the HIV subgroup of patients as compared to the controls. And thereafter, in 2017-18, a paper published in JAMA showed that individuals who are infected with HIV have an increased risk of heart failure with preserved ejection fraction, with borderline preserved ejection fraction, and with reduced ejection fraction, and it generally tends to occur decades earlier than their counterparts who are non-HIV. So it is important that we are aware that these things are there. As we know, this in the next couple of slides is just a diagrammatic representation of what exactly goes on. We are not sure what is the underlying mechanism leading to this heart failure, whether it is the virus per se, the replication, the autoimmunity, the mitochondrial injury, which is uptake leading to heart failure. It is the autonomic dysfunction, as well as the opportunistic infections, the antiretroviral therapy, or micronutrient deficiencies, which may be there concomitantly in patients with HIV, or because of their lifestyle of alcohol abuse or tobacco use, which may add to heart failure. So these are some of the things. This is again a representation. So there are the traditional risk factors which always shall be there. So as our patients are living longer, where there will be more diabetes, there will be more hypertension, there will be dyslipidemia, some of them will be smokers. So that will contribute. Myocardial disease per se, because of fibrosis, steatosis, and myocardial infarction, will eventually lead on to heart failure. As we've seen, the viral infection per se, because of the cytokine production or direct infection, or because of this of opportunistic infection, and because of immune dysfunction and malignancies, or vasculopathy, that is vasculitis, coagulopathy, capillary leaks, and endothelial dysfunction, all can go on to leading to heart failure. So this is again just a paper published in Circulation 2014, again just highlighting the effect and the damage of the virus per se and leading to heart failure. I'm not going to the details of this. This again is a paper published in the Journal of American College of Cardiology, where they've studied protease inhibitors and cardiovascular outcome in patients with HIV and heart failure. And they studied the cardiovascular mortality as well as the 30-day readmission in people living with HIV who were admitted with heart failure and who are having a PI versus a non-PI based antiretroviral therapy. So what they found out was that those living with HIV who were hospitalized with heart failure, ritonavir-based protease inhibitors increased the cardiovascular mortality as well as the 30-day heart failure readmission. So there was increased mortality and 30-day readmission. So that is something which should. Going on to myocarditis. So this was a study which was done long back, probably pre-ART era, when a lot of people were not on good ARTs. So what they found out that the 50% of AIDS patients who died due to non-cardiac reasons were found to have myocarditis. This was an Italian group study. And what they inferred were probably it was because of direct HIV invasion, fungal infections, HSV, Coxsackie B5, parvovirus, and MTP, NTM, and parasitic infections like Chagas disease, which or toxoplasmosis, which may lead to myocarditis and eventual mortality. Cardiomyopathy and systolic dysfunction. These are other, I will be just discussing the mechanism, just briefing about that there may be pericardial disease, pulmonary hypertension, and elevation of lipid levels, depending on patient having dyslipidemia, duration and type of ART used, and impaired cardiac strain may lead to myocardial steatosis. So this is just a diagrammatic representation of the complications which we discussed in the last couple of slides. On your left, you can see the pulmonary arterial hypertension, which probably is as a result of endothelial dysfunction and a pro-coagulant state, vasoconstriction and endothelial production, leading to pulmonary arterial hypertension. Iotopathy, where there is occlusion of the vasa vasorum, the aortic regurgitation and aneurysm formation, leading to iotopathy. Going on to cardiomyopathy, which may be a direct result of inflammation, immune dysregulation, opportunistic infections, and cardiac steatosis. And obviously, pericardial disease, which is there, we know is because of inflammation, low immune status, and co-infection because of tuberculosis being the most common. But rarely we have seen, we do not overlook other because of the immunocompromised state like nocardia and CMV. And malignancies rarely in advanced HIV with lymphomas and Kaposi sarcomas are a surprise there. So we have to get a diagnosis and keep our mind open if the patients are not improving and have this kind of a presentation. And hypoalbuminemia is another cause which can cause pericardial disease. So just a word about pulmonary arterial hypertension in HIV patients. It is a very rare phenomenon. I'm sure not many people, some senior colleagues may have seen, but it's very unusual nowadays to be seeing. Prevalence is 0.5%, and there is no direct correlation between CD4 cell HIV viremia or the duration of illness. And it is occurs without any documented thromboembolic disease or IV drug abuse or any pulmonary infections. As we just saw, the pericardial disease, which is the prevalence of symptomatic pericardial effusion before the advent of ART was quite high. So it was up to 11% according to a paper in 1995, but it is much lower in the current era. And there may be subclinical myocarditis and tuberculosis. And the other causes, as we discussed previously, also with bacterial infections, Kaposis and lymphoma, and less incidence per se of constrictive pericarditis in these patients because of low immune response. Infective endocarditis, we would think would be at higher chance, but if you see the HIV, non-HIV setting, both the risk and the profile of epidemiology is quite similar in both the groups. It's only the IV drug abuser group which is at increased risk of getting infective endocarditis. Staph, strep, and the salmonella species being the predominant positive organisms, and non-bacterial endocarditis entity may present with silent large private vegetation in the cardiac valves on that too on autopsy findings. The most important being currently is the coronary artery disease. As we've said that longevity is increasing, comorbid illness is there. So there is a risk of premature coronary artery disease, and various different mechanisms have been proposed. So it is not, which is something new. If you see the first case in 1990, when they had a patient of acute MI and non-bacterial thrombotic endocarditis with DIC in a severe hemophiliac patient who turned out to be HIV positive. And over the next couple of decades, the burden of atherosclerotic cardiovascular disease in people living with HIV is almost 2 to 3 times higher what it was when it was first picked up. And this is just a slide which I'm not going into detail, maybe difficult to see from a distance, but it is basically the pre-ART, the first generation ART, the contemporary ART, the optimized ART regimens, and the curative therapies what are being touted as, and how the inflammatory and immune status and the cardiovascular complications have been changing from pericardial effusions going on to atherosclerotic heart disease, heart failure, and that is how the progression is happening with the longevity and better ART regimens. This is again a representation. This I was not myself very aware prior to looking up the literature for this current talk, that HIV is associated with thoracic and abdominal aortic aneurysms. It was a prospective matched cohort study, and they found that people living with HIV had 4-fold higher risk of aortic aneurysms compared to uninfective controls. In the HIV status was independently associated with aortic aneurysm. So something which needs to be looked into. And people living with HIV, AIDS, obesity, and hepatitis B co-infections were associated with higher odds of aortic aneurysms. And there was an editorial similar on this, which said that HIV infection and aortic aneurysms, a similar story, but in a neovascular bed. So this felt that this is how the complications of this aortic aneurysms are leading to affecting all vascular system, whether it is leading to stroke, whether it is peripheral arterial disease or cardiovascular disease. Just telling you, cardiovascular malignancy, late HIV, Kaposis and cardiac lymphomas, non-Hodgkin's lymphoma, 20 to 60 times more in the HIV infected patients. Dr. Neha also discussed this in the morning. And this slide just sums up the whole thing, how the thing is happening. So it is where you have to intervene and what is to be done. The HIV infection per se leads to immunodeficiency, can lead to CMV reactivation, activation of adaptive and innate immunity, chronic inflammation leading to thrombosis and atherosclerotic cardiovascular disease. So we have to see where we have to intervene. So immunodeficiency, the only way is continuous or early initiation of ART. If there is any infection, something like CMV and anti-CMV therapy. So these are the ways we can control the chronic inflammation. If there is inflammation or thrombosis, setting in anticoagulation. And if there are dyslipidemia is there because of chronic inflammation, so lipid lowering agents would probably counter that. And if there are anti-inflammatory strategies are there which needs to be taken care so as to prevent endothelial dysfunction and vascular inflammation, thereby the drugs like cardiac inflammation prevention and heart failure prevention by beta blockers, ACE inhibitors, and the newer SGLT2 inhibitors, which have come up in a big way apart from diabetes management and heart failure and endothelial dysfunction and vascular inflammation reduction. So these are how we can probably delay or control the complications of the virus per se. So to conclude, widespread use of ART has been associated with dramatic reduction in HIV-related mortality, but cardiovascular disease and heart failure on an increase in the HIV as the mechanisms are manifold and are incompletely understood as of now. Heart failure along with diastolic dysfunction has come up as the dominant form of HIV-associated CVD in the era of ART. Early and prompt treatment has no substitute. Thank you so much. Thank you.
Thank you, Dr. Ogia, covering the almost all aspects of the cardiac disease. But most important is the ultimately remain the ischemic heart disease most important we see because of the routine ART use, other complications in quite late cancers and mutations. Newly, which is the cardiac failure, that will be the cardiac failure. Possibly, maybe interpreted or relaxation of cardiac muscle problem. Thank you very much. And I'm saving our time to 5 minutes for the lecture. Thank you very much. Similarly, next topic is the importance of the uncontrolled diabetes management again metabolic disorders by Dr. Anivita Agrawal from Delhi. He is a consultant at Gangaram Hospital in Delhi.
Very good morning. For this opportunity. So with this talk, I would like to address a few questions that what is the need of this talk? Does HIV actually increase diabetes? Are there metabolic syndromes that need to be addressed, which are directly correlated with HIV? What are the issues with diagnosis? Is there any specific consideration that we must take care of during the management? And is there risk of increased complications and how should they be managed? So let's review the epidemiology. So to begin with, the initial study suggested that there was increase of almost 1.92 per 1,000 patient per year in follow-up after 6 months of ART therapy. However, this was very similar to the general population. The subsequent studies ended up discussing us that there is a discrepancy in the prevalence because of various factors. That is that the definitions of HIV with diabetes and the criteria used for diagnosis of diabetes are very variable. So there was a study which was performed which is popularly known as the MAP study, which incorporated European nations, US and Australian nations, where they found out that almost there's 4-fold rise in developing diabetes in men who are on ART, which were adjusted for their age and BMI. Subsequently, there was a study which was primarily done for assessing the cardiovascular risk factors known as the DAD study. And the secondary outcomes were also to assess the diabetes and the various other risk factors. And they found that 5.72 cases per 1,000 patient years in follow-up after 3.5 years was increased because of ART per se. So does the virus play a role? So in subsequent slides, we'll be discussing about lipodystrophy. So virus per se, the HIV virus per se, increases the abdominal fat distribution. It causes lipodystrophy. It causes accumulation of fat in liver and muscle, leading to peripheral resistance of insulin. And there are various molecular changes that it incorporates. It alters cytokines, it alters mitochondrial dysfunction, it causes lipolysis, proteolysis, it increases the SOX protein, which increases insulin resistance. It can even alter the gut microbiota, which increases polysaccharide, leading to various dysglycemia. And also, iris per se can cause increased inflammation. And in rare cases, it is reported to cause the production of anti-insulin antibodies, leading to a picture similar to type 1 diabetes, leading to severe accelerated hyperglycemia. So, as we know, general factors which contribute to metabolic syndromes are advancing age, male gender, high BMI, greater waist and hip to ratio circumference, and lower socioeconomic status. With HIV, there are certain specific factors which also add on to it. So the longer duration of HIV infection has been found to have increased risk of metabolic syndrome. There was a study in which lower CD4 count of less than 300 versus that of more than 300 had an additional risk ratio of 1.67, causing metabolic syndrome much more than non-HIV patients. Higher viral burden at the start of ART also increases the risk of metabolic syndrome. So diabetes is prevalent of around 5 to 9 times higher in those who have metabolic syndrome. All these have a very strong interplay in increasing the mortality and morbidity of the patient, which need to be screened as early as possible. So what is the impact of this metabolic syndrome? The various studies which describe that even 2 to 3 kgs increased weight gain within 1 year of initiation of ART ended up leading to a risk of 14% of diabetes in patients. The DAT study also had an interesting finding where 1 kg per meter square BMI gain within 1 year led to 12% increased risk of diabetes. And as we all know, integrase inhibitors are getting infamous for sudden increase in weight, and they are worsening the situation, and they're making the metabolic syndromes more prevalent. Let's have a few words about lipodystrophy. This is one thing that as a clinician, we must clinch as soon as the patient walks into our clinic. So lipodystrophy basically means redistribution of adipose tissue. It is manifested as abnormal accumulation of fat leading to central adiposity. And there is subcutaneous fat loss in the face, in the supraclavicular region, and in the buttocks. So zidovudine and statudine, which were the initial ARTs which were used, they were infamous for causing lipotrophies. And this, however, was a reversible phenomenon. But protease inhibitors end up causing lipohypertrophy. And even change of PIs does not show any reverse in the fat accumulation and the redistribution. So this is a severe cause of insulin resistance, and this need to be identified as earliest. And we should consider switching the ART if we are able to identify this. So here's an image which shows that there is central hollowing of the face and there is loss of muscle mass in hands and limbs where the veins are more visible. We might confuse that the patient is very muscular, although there is subcutaneous fat loss because of which it is seeming like a pseudo muscular person. Then there is central obesity, there's increased fat in the mammary areas, and there's a buffalo hump like a picture. So what does lipodystrophy actually do? So there is subcutaneous lipotrophy and it reduces leptin and adipolectin. And then there is visceral adipose tissue accumulation, which increases lipolysis. This essentially leads to ectopic fat deposition. The fats get deposited into the pancreas, leading to decreased insulin secretion. The fat gets deposited into the peripheries in the liver and in the muscle, which leads to increased insulin resistance. This interplay is very important for us to understand how even slight amount of metabolic syndrome can end up causing severe insulin resistance. Now, as we discussed, the first generation ARTs were very clearly associated with diabetes. However, this was very well seen in the studies which were there, which demonstrated the rise of diabetes in HIV through 2007 and 2009, where statudine and zidovudine were mainstay of treatment. However, this reduced from 23 per 1,000 patient follow-up years to almost 5,000 patient follow-up years with the current treatment guidelines where zidovudine and statudine are no longer the first-line management. So whether now diabetes is directly correlated with a change in ART is not sure. But there were studies in which efavirenz showed a mean blood glucose level of raise of 4 milligram per deciliter, which is hardly significant. So let us review how do these ARTs actually disrupt the insulin metabolism. So to understand this, let us look at this diagram. So insulin basically acts at the insulin receptors of the cell surface, which further downstream regulate the pathway through the IRS1 and 4. This IRS1 and 4 is the mainstay. This further leads to the downstream pathways, which acts on the GLUT4 receptors and which mediate the glucose transport. Now, what happens in NRTIs is that they inhibit the mitochondrial function and they lead to intracellular lipid deposition. This leads to various reactive oxygen species and they directly inhibit this IRS1, leading to insulin resistance. Also, similarly, protease inhibitors also lead to IRS1 inhibition, leading to insulin resistance. And additionally, protease inhibitors also directly inhibit the GLUT4 receptors. And these are the proposed mechanisms by which a longer duration of ART can actually accumulate dysglycemias. This incidence is increased with the duration and with the cumulative exposure. So there are certain other causes which are known to cause diabetes. So initial years where pentamidine was used for PCP prophylaxis, there was rapid onset of insulin deficiency and there were patients who presented with ketoacidosis. This is because pentamidine directly destroyed the beta cells of the pancreas. There are certain opportunistic infections of pancreas and lymphomas like Kaposi sarcoma, which can lead to islet cell destruction and causing diabetes. Then the steroids that are being used, megestrol acetate, that is a potent glucocorticoid action causing insulin, decreased insulin secretion. And secondary pancreatitis with even drugs like cotrimoxazole is known to cause worsening of diabetes. Co-infections like hepatitis C is well known to cause insulin resistance and diabetes, which should be catered very carefully. Now, integrase inhibitors are the much talked about in the first line ART therapy. So the pathophysiology that is hypothesized is that they are able to chelate the magnesium at cellular level, which affects the GLUT4 transport receptors, and they cause insulin resistance directly. There is evidence for weight gain, which is growing in literature, along with association with tenofovir alafenamide. However, TDF, which is most commonly used by the NACO program, is not found to have a similar association. Metabolic syndromes are also increasing along with integrase inhibitors, and this severe weight gain could be a future risk for developing diabetes. There is ongoing evidence about it, and there are multiple case reports which have shown that there is accelerated hypoglycemia, and the patients have come up with ketoacidosis in emergency as soon as they've been initiated on integrase inhibitors. And this was preceded with certain weight loss, which was easily identified by the clinicians. Then there are observational studies which have contradictory evidence whether it's directly leading to metabolic syndrome and diabetes or not. Then there was a meta-analysis that was recently done in which integrase inhibitors were not associated with increased risk of diabetes. This was compared with protease inhibitors and NNRTIs, but in African population, they found an increased risk. There are further studies which are ongoing, which will be able to answer this question soon in the future. Now, as clinicians, it's important to understand what are the screening strategies and are they different from the general population or not. So according to DHS, they recommend that fasting plasma glucose should be done, and it should be done every 6 to 12 months in HIV infected patients. And it should be done within 1 to 3 months of starting or switching ART. And NACO guidelines are also on the similar line. However, they recommend random blood glucose testing. So they recommend that within 1 to 2 months of initiation of ART and every 6 monthly, blood glucose monitoring should be done. And if a change of regimen is done, even at that time, blood glucose monitoring should be done. So what are the criteria that are used? So for general population, ADA recommends, as we all know, 126 milligram per deciliter of fasting glucose, more than 200 after OGTT, and an HbA1c of equal or more than 6.5. However, we should understand that in HIV, the HbA1c is inaccurate. It underestimates grossly. There were various postulates because of which that happens, either hemolysis, either NRTA per se, they're particularly abacavir is strongly associated with reducing the HbA1c. Also, macrocytosis with secondary thymidine analogs, which is no longer used, can lead to reduction in HbA1c. So how do we address this question? HbA1c is our mainstay for diagnosing as well as monitoring therapy. So there was a study which was done, which depicted the ROC curve. Here we can see that when HbA1c of 6.5 was seen, the sensitivity falls to almost 40% in HIV positive patients. And however, the specificity is maintained. When they reviewed the AOC curve, they figured that at HbA1c of 5.8 is where the sensitivity is achieved of 81%. So where does this lead? Does that mean that we should use a lower target? This has, however, not been reciprocated in any of the guidelines as of now, but this helps us understand that we are probably underestimating the burden of HIV. Also, fructosamine, which is difficult to obtain, is a much better substitute for HbA1c in such patients. Hence, the primary mainstay of diagnosis and monitoring has to be fasting or postprandial plasma glucose levels. Now, for treatment of HIV, there's not much in RCT. There are not specific recommendations. Hence, the general ADA guidelines is what we must follow. The pharmacological therapy is no longer according to the hierarchical pattern that this is first line, this is third line, this is second line, but it's individualized. It has to be based on the patient's needs, comorbidity, and tolerance. So we must understand that there is pill burden, there is drug interactions, there is poor compliance, and there is poor absorption of the drugs. Hence, all these factors must be taken into account before prescribing drugs. Lifestyle interventions are the paramount, as we all know, amongst when we are routinely treating patients. We must take them to a dietitian and advise nutritional counseling. This is very, very important. Exercise is important. It has to be emphasized. Now, this is the familiar ADA algorithm where we understand that the first line therapy has to be based on patient's comorbidities, its treatment factors, and according to the various considerations, depending on the ASCVD risk, whether the patient falls into high risk with heart failure or CKD, SGLT2 inhibitors and GLP-1 analogs are the mainstay of treatment. However, if these comorbidities are not there, we can moderate the treatment depending on the patient's other characteristics. So there's special considerations that we must review. Once we're using metformin, there are certain factors that we must take care. Although it's not the mainstay of treatment anymore, but it forms an umbrella picture. It is one of the most commonly used drugs. Hence, interactions with dolutegravir must be seen. Sulfonylureas although did not have much drug interactions, but absorption and hypoglycemia remains one of the most common side effects and most common faced difficulties. With metformin, we must understand that it needs to be avoided in patients who have tuberculosis, weight loss, or cachexia, because they have a chance of increased lactic acidosis. And hence, it is contraindicated in patients with severe renal dysfunction and cardiac failure. Now, we must understand that metformin is eliminated via the renal tubular secretion, and this step is inhibited by dolutegravir. Hence, the dose of metformin has to be capped to not more than 1000 mg per day as the levels increase. With pioglitazones, there's a slight possibility of increase in subcutaneous fat. So this makes it preferable to use in patients who have lipodystrophies. However, we know the common side effects of weight gain, of various esophageal cancers, as well as risk of cardiac failure, which must be kept in mind. With other OHAs that are available, we must make sure that drug interactions are taken into account. There are various drug interactions like sitagliptin interacts with CYP3/4 inhibitors, and its dose gets reduced. And similarly, dapagliflozins have to be, when co-administered, they have to be increased. Now coming to complications. With microvascular complications, peripheral neuropathy, as same as the general population, the distal symmetrical peripheral neuropathy is the most common. Hence, NACO as well as DHS, they recommend that foot examinations must be done every 6 to 12 months when the patient comes. For retinopathy, CMV retinitis used to be a common factor, and this used to often complicate the diagnosis and detection of diabetic neuropathy. However, its rates have reduced. So an annual ophthalmic examination is very, very essential. When we look at nephropathy, HIV-associated nephropathy as well as diabetic nephropathy, both utilize the albumin-creatinine ratio as the criteria. Hence, it's difficult to ascertain which of the following the patient is having, and it's difficult to treat. Tenofovir also increases the tubular dysfunction and causes AKI and CKD progression. So a good blood pressure control, lipid control, and spot urine microalbuminuria must be assessed every 12 months. ACE inhibitors and ARBs need to be given in patients who have hypertension or microalbumin in blood. Further on, both diabetes and HIV are a common major cause of cardiovascular mortality. So when we take out the ACVD risk score, ACC recommends that HIV has to be included as a risk enhancing factor. So if the ACVD score is coming as an intermediate between 5 to 7.5, HIV status is a good enough reason to start statins. And statins as primary prevention is upcoming, and currently there's an ongoing prospective study which is trying to cater to this very question. Here I conclude my talk. Thank you. I would like to take the next.
Thank you, Dr. Anita Dua, for comprehensive presentation about the citizens of the diabetes and HIV. We have likely experienced the morphological changes, the physiological changes, the molecular changes with regard to the diabetes mellitus, how the lipodystrophy and then how basically frequently we have to screen the HIV persons and what methodology to use, then what is the appropriate treatment, how the metformin is actually by this complication related. So you have to avoid the aspects of the diabetes. Thank you. We'll have the questions. Next session is by Dr. Yotina from UK, and she's going to make a presentation on the emerging STIs among the PHIs. Over to you, Dr. Nath.
Right. Good morning, everybody. I would like to place my thanks to Dr. Bhuva and Dr. Kumar for giving me the most glamorous topic of the conference. Thank you very much. We're going to do an exploratory exercise. What am I going to talk about? I'm not going to talk about STIs in broad details, but I'll talk about the resurgence of some of the STIs, some of the challenges that we face managing this group of patients. We'll talk about some of the newer infections, the opportunities that 2023 has to offer to us, and our role as a healthcare provider in managing our patients. Hopefully, I'll be on time. Increasingly during the COVID epidemic or the pandemic, we found that there was a low coverage of testing, treating STIs, but subsequent to that, where in countries where there's proper recording and surveillance data, we are continuing to see some of the infections like chlamydia, syphilis, gonorrhea on the increase, as is indicated here, and some of the non-classical STIs, that is Shigella, on the increase. Other infections are more or less stable when we talk about herpes and TB. And you all know there's a declining trend of HIV and of HPV as well. In 2020, we were talking about acquiring 1 million plus STI infections on a regular basis daily, a mammoth number. I don't know how many it is in 2022, but when we look at the big fours and the big viral bacterial ones, what strikes you is all of these infections are curable. We can treat them. And if you look at the two main viral infections, that's your HPV and hepatitis B, forget about HIV. Again, they are preventable. You can prevent nearly 300,000 deaths through cervical cancer if you implement your HPV vaccination. And again, prophylactically, if you provide hepatitis B virus vaccination, you can prevent the scourge of misery through hepatocellular carcinoma and cirrhosis. So something to ponder about when you see your HIV positive patient. Just check whether they've been vaccinated. I'm not going to talk about that. Furthermore, when we look at the burden of infection, it depends on where you are seeing your patient. In industrialized countries where I work, usually I see men being infected, but where you work, the burden falls on the woman. It's not just for HIV, but also the children suffer the consequences of these infections with stillbirths, deaths. And you know, I'm sure many of you have dealt with PID, secondary to chlamydia and gonorrhea, primary and secondary infertility, scores of patients like that. So there is a huge burden of infection. What is important to differentiate when we are talking about STIs is how has the infection been acquired? Is it through vaginal, oral, or anal sex, which is responsible for vertical transmission, mother to child transmission, which is obviously non-sexual? And what are the infections that may be acquired through close contact, but without sexual contact? So don't mess it up, because I've heard arguments about these people messing things up. Your hepatitis A, B, C, Shigella, Giardia can happen without sexual contact. And you're emerging new infections like monkeypox and HDLV or other areas as well. Why is this group of people important? Because what you're providing to this subpopulation, you follow them for life. They're engaged with you. You're their caregiver. Your care may be related to HIV as per se. It could be due to treatment. It could be they're getting older, so you're continuing to grow old with them, and for public health reasons. The idea is that you want to impact their life, make them healthy, and also have a societal responsibility because it's better for the society at large. However, what you need to remember all the time is this key population, that is your person with HIV, has overlapping risk factors and behaviors. And therefore, when you're tailoring your services, whatever service you want to provide, try and provide some continuity of care so that there is no disruption, because otherwise, there is discontinuation of services that impedes compliance and access. So it's something that you need to think for the future. Interesting facts, 2017, of the 3% of all STIs diagnosed globally, 88% were in MSMs with HIV. Staggering figure, isn't it? So are these people responsible? Are they at increased risk of STI? These are just some hypotheses that I put forward. Are people on ART at increased risk of STIs? Are they at higher risk of transmitting HIV when they've got an STI? There's lack of data in most of these fields. Let's tackle increased risk of STIs. Acknowledging equities in STI rates is important. And this is an exercise that you probably need to do locally within your clinics. This bore out from the GumCAT data for 2019 from the UK. We report every sexual episode of consultation, we report to the Health Protection Authority in the UK. And what was so evident was that in 2019, that the MSM group was increasingly affected with early syphilis, nearly 41%. But what was most striking was that people with HIV were 3 times more likely to be affected than your HIV negative MSMs. Now, we blame everything on risk behavior, their risk behavior. And we do need to look at, is there a difference in sexual network characteristics? What do I mean by that? Okay, so if you're having sex in a high prevalence area where there's more likely to be an STI, you're more likely to pick it up. It's not a rocket science. So with each sexual encounter, you face a greater chance of infection. So the first step is recognizing that there are inequities in STI rates. Second, people with HIV on ART are at increased risk of STIs, right or wrong? I'll point towards some evidence. Basically, we know that condomless anal sex has increased globally. And there's enough evidence, I don't need to present it to you, supporting that. In 1998, there were only 24.3% having people with HIV having condomless sex, but in 2008, it has increased to 36.6, quite a staggering figure. They have increasing number of sexual partners, they have concurrent partners, and chemsex. What is chemsex? Chemsex is a term that has been coined when people voluntarily take psychoactive drugs and non-psychoactive drugs. I'm talking about things like gamma butyrate. I'm talking about things like Viagra. I'm talking about things like poppers, amyl nitrate, methadone. And these people take this to enhance their sexual activity, for enjoyment sakes. But what happens in the process is they get rectal, they have penile abrasions, there's rectal trauma, and there is just quicker transmission of STIs. So that's chemsex. So asking your patients whether they do recreational drugs and things like that becomes important. You know about the dating apps. How many people are on Tinder? It's a joke. Or Scruff. Scruff is your local dating app. In our eagerness to promote use to you, where we said it's fine, you don't need to use a condom, we remained oblivious to the risk of STIs. And obviously, there are lots of condom myths in people who are MSMs and who are HIV positive. I'm not going to elucidate on those. So, is there a higher risk of transmitting HIV? Post-heart, there's studies show no impact. Unfortunately, there is a lot of lack of data as HIV has been in one silo and STIs has been in another silo. Fortunately, WHO is changing this equation. Another observation, and I'm just picking up observations. I'm not, Dr. Toshniwal did a very good job of talking about syphilis. I'm not going to talk about that. I'm just giving you some observations, some recent observations. We presume infection in syphilis to happen through infectious agents, okay, through infectious lesions. This is a fascinating Melbourne study where they took MSM, asymptomatic MSM HIV positive people who had no lesions at all, did their NAT testing, PCR testing, and I'm looking for TREP DNA. And guess what? In about 20 to 85% of their patients, they saw positive DNA in their saliva. Okay. But remember, they were all asymptomatic. They had no lesions at all. And they saw similar findings in their anal swabs that about 5 of them had a positive PCR. So this raises the question about, does infection continue even in the latent stage? And we are seeing a lot of it, about 50% globally. Infection is happening in the latent stage. And there's a study from India where a quarter of the cases they've shown infection during the latent stage. Now, this has implications for policymakers. What do I mean by that? You need an early diagnosis. You need an early treatment to stop transmission. Do you know that congenital syphilis has increased by 460%? So if we do want to make a dent in syphilis, we need to look at other ways of resolving this. We've ascertained that there is an important epidemiological association between HIV and syphilis. We all recognize that. Has it made a clinical impact in these patients clinically? I'm sure many of you reported case presentations of multiple painful ulcers. Okay, we all know that. But atypical presentations has been the norm in most of our patients. Otic syphilis, that means they become deaf, but then regain it once you give them penicillin. Uveitis, stroke, a manifestation of syphilis has dominated our clinics in the UK. Early case reports suggested a rapid progression in these patients to neurosyphilis that has not been borne out with recently well-controlled studies. There's no impact on neurosyphilis. When I was preparing this talk, I was thinking, well, what dilemmas do I face? And I came up with this list, the clinical dilemmas that I face and the diagnostic dilemmas that I face, and I'm going to share them with you. The first is an inadequate serological response. What do I do in a positive patient who is not responded? Fortunately, the CDSC has come to our help. Recently, they've come up with the suggestion, stop testing them, okay? If somebody has primary syphilis, wait for 12 months and then test them. If somebody has latent infection, you've treated them, don't bother testing them. We've had several entities about, should we give 1 injection? Should we give 3 injections? The jury is out on that. Hopefully there's going to be a randomized control trial run by Europe to answer this question. When should I repeat CSF in my patient, okay, with neurosyphilis? Fortunately, the recommendation now is if the patient is on heart and they have shown a serology response, defer your CSF repeat for another 6 months. Thank God for that. What if my patient is allergic to penicillin? Desensitize him. That's what they say. There is a quandary about how much doxy should I give, 2 weeks, 1 month. Some people give 2, some people give 3. The world's your oyster. When I looked at diagnostic serology, it's a mess. It remains imperfect. Whether you use your traditional testing or you use your reverse sequence testing, there are limitations. There are problems with it. Treponema cannot be cultured or isolated. There's a low pathogen load. Unlike GC, you cannot sequence it. Swab, if you use a swab, it picks up less than 1% of your DNA, and that means DNA enrichment, which is not possible. So NAT testing is the way forward and has been for us for probably about 2 years, 2 to 3 years. It's a cheap site addition. You can add it to your multiplex panel, and especially in places where there are endemic STIs, it's probably a good tool for you to have. There is also a move away from dark field microscopy to PCR in our place. And we're using it as an additional tool to pick up mixed cases or negative serology. It's useful in inexperienced hands in small units. We're training staff to swab anything. They've been swabbing monkeypox as well, to swab extragenital sites while they've done their bloods. The results come back in 6 to 8 hours. You start treatment immediately, and that obviously impacts transmission. And there are these 2 studies, one from Dean Strait, to show that when they looked at 14% of their samples, which were positive for PCR, TREC DNA, when they cross-referenced the serology with serology, 1 in 6 had yet to become serologically positive, showing how early you could pick up infection in these individuals. Moving on to, that's syphilis for me, moving on to monkeypox. Monkeypox has been there, it's not new, it's been there in Central and Western Africa, but it's only because when it shifted out from its endemic area and affected other parts of the globe that it became a problem. Sexual transmission outbreak was also identified in Nigeria in 2017, but it was confined to the endemic area, so it didn't become much of a global problem. But it assumed global proportions because every country in the world was reporting cases. What was interesting about this, more than 99% of the cases were male, 95% were gay or bisexual men, 95% had sexual contact as suspected route of transmission. And what was interesting was that 41% of these people were HIV positive. So, history of an STI in the past year and being HIV positive showed that these people were nearly 61% of these people were disproportionately affected by monkeypox. And now you can see they were doing incredibly well. Most of them had HIV RNAs less than 200 copies, and they were not hospitalized. But however, what was different was in these people, they had more rectal symptoms and rectal manifestations. And that's why they presented to us in our clinics. With what? Proctitis. That was one of the common presentations that we were seeing in our clinic. Pain, and I mean, we were thinking herpes, blah, 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 syphilis, gonorrhea, all the rest. But that's what it was. 17% of presentations of proctitis. You may get rash or pox-like lesions, and we talked about PCRing them. But remember, there will be concomitant STIs in your patients, as this data shows that 3 of the wonderful infections, GC, chlamydia, syphilis, that's a proportion of infection that they had. So what were we doing? We were not proctoscoping them because it was exquisitely tender to process. I mean, they would hit the roof. Slides were not done because these slides are category 3 stickers with category 3 infection. So chances of infection to the healthcare professional, they were not to be done. And these patients were managed syndromically. Skin lesions, what do you do with the skin lesions? This is an example of some of the lesions that they can present with. And you basically, this is the kit that you use your PCR and you send them off. Now, was there any difference in the treatment and the outcomes in these patients from your general population? Not at all. Most of them, there was no difference either in clinical presentation or in hospital admission. However, there was a CDC guidance that came in. The people who had CD4 counts less than 200 should be either monitored or should be offered, should be prioritized for antiviral and immunoglobulin. So who are the people that you could consider severe? Anybody who has a severe disease, large number of lesions, who is septic, encephalitic, who has ocular problems, who needs hospitalization, consider antivirals. But otherwise, monkeypox is a self-limiting disease, okay? Where you suspect there's going to be an involvement of an area like the penile foreskin leading to adhesions and possibly leading surgical resection, introduce your antiviral. And obviously, people at high risk have already talked about HIV positive, immunocompromised and poorly controlled HIV patients. Now, if your patient is already on ART, and is there likely to be an interaction with your antiviral? Although co-administration has not been studied, it is believed that tecovirimat will decrease your rilpivirine concentration only. No other drug. It will have impact on no other drug. So what do? Increase oral rilpivirine to 50 milligrams daily during co-administration. And obviously nobody here, I mean, from my understanding from yesterday was that there's nobody on long-term and long-term antiretrovirals, but if they are, consider an additional 25 milligram oral dose when you're thinking of introducing your antiviral. And obviously don't start them on anything. What about people who are exposed, post-exposure prophylaxis? The way we were dealing with it is that if they've had smallpox before, we would say, go home, monitor. Obviously, we would examine their scar, which is usually on the left-hand side, and with a little depression, that's fine, go away, you'll be fine. But if somebody has been treated, okay, and there's no evidence of smallpox, if their CD4 count is more than 200, then you give them your MBA. I'll just quickly finish off. And if they were a smaller dose, 0.1 mil intradermal shot, and otherwise you give them a full dose if their CD4 count is less than 200. So the take-home points are that people with HIV have been disproportionately affected. We are not sure why. Outcomes are good with good CD4 counts and offer antivirals for people with less than 200 CD4 counts. Is it okay if I continue? Okay, I just want to explore some sexual health paradigms with you. Now, we're looking at new ways of supporting sexual health and general well-being. Why do we do that? We tell them have sex, but at the same time, we want to reduce the burden of sexual disease and the consequences. But it will take a long time for clinicians from all types across all spheres of health spectrum for really to make a change. So when a patient, and this is an important question for you, please, when a patient comes to you, what do you think his expectations are? He thinks that when you're testing him for STIs, you're telling him that you're going to be clear of STIs, he can be treated easily, he's asymptomatic, so whatever you tell him, he's not got an infection. And are we currently meeting, I want you to think about it, are we currently meeting these users' expectations? And are we providing a good quality of care for these patients? I am afraid, I think not. Because what we are providing them, is it fit for purpose? Your syndromic case management, which has remained the cornerstone of STI control, performs very well for vaginal infections. But do you know, it only picks up 5% of, we know that only 5% of your women are adequately treated for chlamydia. Many infections are asymptomatic, as I already said. You need an etiological approach. You need molecular assays. Do you use them in this group of patients? I'm talking about in this group of patients. No, you don't. You need susceptibility patterns to your antibiotics, which are critical to inform your treatment guidelines. Are you doing that? Not at all. And how are you able to address antimicrobial resistance, drug resistance? And we talk about giving doxyprep. With what in mind? Okay, have you thought about the consequences? And do we know what is the magnitude of STIs within our country? I don't think so. Why is it important? These are some cases that we've had, cases of supergonorrhea, because antimicrobial resistance is a problem in gonococcal infection. This is countries where Cipro is 100% resistant. Azithromycin, India tops it, okay? Unfortunately, ceftriaxone, we are still safe with it. So at the moment, we have huge challenges. I won't talk about this. Challenges managing gonococcal infection. We already have one case of ceftriaxone resistance in the UK, and 2 have come from Australia. This has also impacted, azithromycin resistance has impacted on Mycoplasma genitalium, Shigella, and Campylobacter. It's the next superbug that is likely to make people infertile. I just wanted to mention about hepatitis C, because I think you guys are well placed to manage these people, because you've got good treatment now, you've got direct acting antiretrovirals now, and there's enough studies to show that the SVR in this group of patients is as good as any other cohort. So it's time to take our hands out, look at the opportunities that we have to offer. We've got rapid tests, we've got effective treatments, and we've got the global health with you. The self-collection of swabs can be encouraged. I would request you to screen your patients at least annually with syphilis, gonorrhea, and chlamydia. Do their syphilis serology, and you'd say, well, what if they're asymptomatic? They're not, they don't have an infection. So just to take some data from asymptomatic people with HIV showing bacterial STI rates of 11%. And look at that. They had chlamydia, gonorrhea, and syphilis at the rates that I've mentioned here. Okay. So why do I need, the next question will be, why does everybody need triple swabs? This is a doxyprep study which shows that the STI incidence, which whether you look at a PrEP cohort or you look at an HIV cohort, you have more than 2 site involvement with STIs. So I will end with saying we have to have a common vision. We need to create an environment to discuss STIs and adopt safer sexual practices. There needs to be a scaling up and integration of STI services within this group, and we need to facilitate adoption of point-of-care diagnostics. Thank you very much. And it's like doing war. Do you know what this is? This is during the war, they would ask people to whatever scrap they had to put it together so that they could use it to build Spitfires. I think we are in a warlike situation, and we need to get our hands out and do what's best for our patients. Thank you very much. And thank you for giving me the time.
Thank you, Dr. Jyoti. Excellent coverage on STI. Basically, monkeypox may be new to the audience or to the doctors. The forum is open for discussions.
My first question is for Jyoti only. So, and second question is for Anita. Jyoti, yes, we know that studies are on rise. Tinder, Grindr, they're playing a great role. Young people are coming over with infections with HIV or without HIV. The problem in managing syphilis is availability of penicillin. The only one company in the country which makes, and that is Jolly Health. The cost of penicillin is 20 rupees. It is not available everywhere. So people have to go around spending 200-300 rupees to find penicillin. The second problem is people who are interested in injecting penicillin. And the third problem is alternative doxycycline and azithromycin doesn't work. We have seen that doesn't work. So only penicillin works.
So I think it's a big challenge of making availability of beds.
I've heard you say several times that India is the powerhouse of pharma or whatever. What you didn't the exact words you use. So what can't you as a collective effort, where we are able to make, why not?
There are problems with the DCGI, which has put this into a list where the price cannot be go up. You can imagine what is 20 rupees. Tea is costing more than ministry. So if companies are not allowed with price and DCGI put some brake on it, no company is interested in making it. And the first company to get the antibiotic is closed down. So how much the benefit?
Unfortunately, I don't really have an answer for you. To highlight something, we've had a scourge of streptococcal infection in the UK, and I was asked to bring some penicillin for my kids, just in case they got streptococcal infection, because London had no penicillin at all. And they were giving them amoxicillin.
One comment for this question. We are having this national pharmaceutical pricing authority. I think the concerns being raised with this, because that is the regulatory authority to have the price fixing for the pharmaceutical products. So if it is not available, we need to raise our concern to this organization so that they may be concerned properly, and then they may request the company and give some leeway to increase the price. Something have the balance of the product.
I mean, DCGI, but I just said DCGI. Now, my second question is to Anivita. Currently, in HIV management, we are facing a pandemic of diabetes. Almost 20 to 25% of the patients on dolutegravir are having diabetes. So, your initial publication, which you are shown, there are older publications, which shows hardly any marginal difference between on ART and without ART. And so much so that not only dolutegravir, which shifted patient from dolutegravir, same problem. Maybe 5-10% patients maintain on dolutegravir, but almost both of them are same with diabetes. And as soon as you shift the patient from there to atazanavir or something else, they're going back to the drugs. They're stabilizing. I think initially we thought lockdown has played an effect, people have put on weight, but it is mainly these drugs, and we need to have such a other drugs where people are failing on dolutegravir.
Yes, so the studies are there's upcoming evidence about initiation of bictegravir as well as dolutegravir leading to sudden hyperglycemias, leading to metabolic syndrome. But whether there's a direct correlation, studies are still missing. There are ongoing. There are a lot of systematic reviews and meta-analysis that have been published, which are ongoing. But there's not core evidence whether switch should be done or not. But as clinical practice, like you have said, and many other cohorts have published, that the switch is actually reversing the metabolic syndrome, it's reversing the hyperglycemia, it's reversing the weight gain, and the patient is continuing to having the viral suppression. But whether that should be translated into guidelines or not, that is yet to be established.
I have a question for Dr. Vijay. It was a fantastic presentation and was triggered by your last two slides where you showed macrophages with inflammation. My question is, anything known about the TLR 7, 8, 9, which will either the stimulator or the inhibitor, which alters the pathogenesis of the neurological disease or may cure if you do the other way around?
I think it's an area that's still under study. We're very clear in COVID that people were told like receptor 7 mutations die very fast. So I think that the key issue is what seems to be happening in all of these inflammasomes. By the way, there are several hundred inflammasomes described. It's just that we know a lot more about NLRP3. And we do know a little bit about how we modify both the upstream and downstream output of NLRP3. And until we have direct antagonists of NLRP3 or the other inflammasomes of NLRC4, for example, this is a good question to ask. Because I think that what ties everything together to heard one thing that keeps on repeating as a repetitive theme today. It's inflammation, 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 which is why I, as an infectious disease specialist, deal with a lot of immunologically mediated diseases. I'm now focusing on inflammation. And this entire gamut of anti-inflammatory diets, agents, small molecules that reduce inflammation, and some of them go through the inflammatory pathways will be critical for our management of patients.
Go ahead. Yeah. My question is. You go ahead, sir.
One question is for Cynthia. I probably did not understand what you said. After treatment, you don't do any follow-up for citizen.
Sorry, say it again.
You said that after treatment, some people-
If they've had a serological response for CSF, that CSF you're talking about.
but we are seeing a lot of patients right now who are getting re-injections.
Yeah, that's a different, obviously you're.
But so living because they may not have symptoms and their titers just start going up.
Yeah.
And it's not failure of treatment.
Obviously, if they're symptomatic and your serology changes, you probably will repeat their CSF. Because you want to ascertain whether they have got neurosyphilis or they have symptoms suggestive of neurosyphilis. But otherwise, if you feel that you've adequately treated those individuals, there's been a definite response, zero response, then you can leave. There's a need for us to LP them. That's basically what they're suggesting. This is the recommendation from the CDSC. It's not yet in paper yet, but I attended their webinar and that's what they suggested.
There's one more question.
Sure.
For hyperglycemia and diabetes, we have some kind of screening going on. As a clinician, it was an excellent presentation on heart issues. Now, in busy OPDs, especially like ART syllabus, 6 monthly blood sugar is done, but what would be the guidelines for a clinician sitting in the clinic who is treating HIV, is not a MD, general medicine physician? These are the points you pick up early, and these are the investigations you send that patient. When do we do, say, for example, 28 or something like that? Very nice question, very pertinent question. There are no clear-cut guidelines or any recommendations to say that what you should do. But as a practicing clinician, I think, first of all, awareness. As I said, that I was also not aware that there is risk of so many aneurysms, hypo risk there. So it is just about increased awareness. So all patients who are having especially comorbid illnesses, which are predisposing to a cardiovascular disease, and patients who are on antiretroviral therapies, which make them more prone to metabolic syndrome, should be screened for basic parameters for metabolic syndrome. Along with that, you can do a baseline ECG, sugar, cholesterol, and where warranted clinically echocardiogram should be done as a part of screening. Wherever there is a patient who's 45 plus comorbid illnesses, especially those patients.
Last question. My first question is asked by Dr. Kulkarni. As a patient group, my question is to Dr. Atul. As a patient group, we played our role in monitoring our CD4, viral load, and all those stuff. So in CVD, what as a patient group we must monitor ourselves better.
So that's what
the first question may be like, what intervention you told about a parameter, but what intervention can added into the program side?
Yeah. So the additional therapy, as we discussed, are there. So patients who have comorbidity, so adequate blood sugar control, adequate blood pressure control, and statin addition wherever warranted as per the guideline and the guideline protocol should be started. And we have to be aware of the drug interaction also here. That is very important. The main problem is drug interaction. So these are the basic things: good sugar control, blood pressure control, and statins probably are ones which have an anti-inflammatory and protective effect also thereby. So that there is a small role also of colchicine in post-MI patients which in most MI patients, heart failure may happen.
Atul, I was just wondering, like, guidelines for the patients themselves. Like someone who has started developing edema on me. Yes, should be, because the other things are managed, but what are this kind of, you have slight more dyspnea. Yes, you should have that kind of guidelines for the patient groups. Like if you start having whatever,
So I think that is
that kind of a thing, that kind of.
yeah, that is very simple. If patient is symptomatic, patient has signs and symptoms of heart failure, then definitely you have to, investigate. But the most important thing which Dr. Jyoti has also been prompting is the prevention. So good lifestyle management, exercise, weight control, which is most important in these patients because once they are on ART, they are eating well, their inflammation and disease is controlled, and they are taking good diet. So there is a tendency not to do exercise, they are gaining weight. So most important is a regular health checkup in the form of having, their weight control, an exercise regimen, and a diet, which is most important. And obviously, you have to screen if anybody has symptoms which are suggestive of a cardiac illness in the form of new onset breathlessness, dyspnea on exertion, lower limb edema, on examination, signs of heart failure, they need to be investigated.
Thank you very much. Thanks all the speakers for excellent coverage of their topic. And they will know all the time. Thank you very much. This
Yeah,
session is closed. Yeah.
Thank you. It was a wonderful discussion, I think. Now I will request our chairs to felicitate our speakers. Dr. Vijay, Dr. Jyoti, Dr. Atul, and Dr. Amrita. I will request Dr. Mathai kindly felicitate our chairs. We will break for tea only for 10 minutes. Please. Yeah, you can bring your coffee here and we will start after 10 minutes. Start.
There are two teas. One is a low tea here and high tea there. So, please enter both and come. As soon as you come, we'll start first with the online. Yeah. Now next to the ears.
Yes, that's why we. I'm just going to have some tea and I want to.
Nice presentation.
Okay, thank you.
Can you get the summary of the presentation?
Summary. Yeah, yes. I can send it to you. Yeah.
Do you want the PowerPoint? Okay. Okay. So my husband is Alexander Thomas and is the president of NHI. So he and I may got together and part of this presentation is actually from them, but I can send it to you. Okay, yeah, I think it will be very useful. So if you can just give me your. Should Yes, we will.
ASICON conference. Firstly, why did you want to speak about it? Let's say what? How are you going to coffee now? And you want something? You want water? Oh, I'll give you.
I did you? Yes. When I was little, I was the banana was sugar ready. It became so much. Mumbai, where's Mumbai? I'm at the clinic. That's basically. So I don't know my working. I think the consulting there, I only go for information. Area में तो मस्त है तो काफी things happen. Then we get into it. So where do you come from? Yeah, but it's happening in the local people. Make something else. Okay, we are all here together.
So now we will move on to our next session. State of the art, optimizing the old, bringing the new. Very important session. I will invite the co-chairs, Dr. Satya from Sri Lanka, Dr. Mika from Hyderabad. We have the 4 talks in this session. I will request chairs to invite the speaker.
Good afternoon, everybody. We welcome to the free lunch is the third session today. In this session, we will be discussing on the theme optimizing the old and bringing the new antiretroviral therapy. There are 4 topics in this session. Out of the 4, 3 are online presentations. 1 is physical presentation. There is a small change in the presentation order. We are inviting the second speaker. The topic is Dr. Stefano Vella from Italy. The topic is 2 drug disease, the new evidence.
Good morning, friends from India and all over the world that are present. It's the ASICON meeting, and I would like to thank you again for inviting me. As I said in my previous talk, I'm really honored. Probably or possibly I will be next time there in person. But now let me start my presentation of today, which deals with the use of 2 drugs instead of 3 for the treatment of infection. And now, to start with, why do we need to challenge the standard 3 drug pipeline? Different issues. One is maybe consistency, because of course we take out the nuke, and that might be important for toxicities and regarding mainly bone and kidney. Then drug interactions maybe for certain co-infections, these deficiencies and co-infection might be important to look at the drug interactions with 2 different combinations. Of course, there are fewer drugs instead of 3. And then the cost might be. Now the pivotal trial, because there were 2 trials looking at the use of 2 drugs in naive patients, are called Gemini 1 and Gemini 2. They were comparing, of course, dolutegravir TTC versus dolutegravir FTC PDF UD overall again. The results are actually very interesting because they prove that there is not a difference in proportion of viral suppression. Even today that we have the data at 144 weeks, always a long follow-up. Just as a side, I would like to say that there are a lot of studies coming out from real-world evidence of the use of 2 drugs versus treatment, and these are important. But those are the randomized trials, and indeed, these are the different populations in these trials, and overall, you can consider no difference between viral suppression in the 2 treatment arms. There is a little difference actually for the patients that started with less than 200, but the numbers are small, very small. In any case, the guidelines have some guidelines related to these 2 drug regimens. For example, the EATS guidelines say that the patient should be HBV negative because, of course, there is no tenofovir. And then also that they should have less than 500,000 copies. So patients with very high viral may not be enrolled in this 2 drug regimen. And this is in a sense the same in the DHHS and the ISUSA guidelines. The ISUSA also said that it's not recommended for rapid start because, of course, maybe we need a baseline laboratory evaluation in terms of resistance to disease, just to avoid the patient start with just one drug. Let's look at the safety, actually. Safety overall, two big trials is very compared to the numbers and between the two arms. This is in terms of adverse events in general. But if you look at change in serum or plasma renal fiber, which clearly changes are favoring double, triple. This is the same for only better, and indeed, this is something that is confirmed also in another study, which is called Tango, and this is in a sense looking at this. And if you see going to the efficacy, you have better results in terms of patterns. Again, Tango confirmed renal changes favorable to long-term. Maybe we need more data in many patients. For example, when a patient has or a tuberculosis, and also the use in pregnancy. Will you use 2 drugs in pregnant women to stop HIV transmission? And then there is a strategic question. Is it better to start with 2 drugs, or when the patient is stable and undetectable, move again to 2 drugs when the patient started with 3 drugs? So that's a strategic question. I mean, you can start from the beginning, or you can switch to drugs. And indeed, look at what data we have on switching. We have 2 big trials that say, actually, when you switch a patient who is undetectable, 3 drugs or 2 drugs, not one. You only need a very important active nucleoside, transcriptase, and this would be 3TC. If the third agent is a booster PI or a leukemia, so 2 drugs that have a high barrier to resistance. And coming back to the January 1 and January 2, in this subpopulation of advanced disease, you can look at there are no big differences in terms of baseline and shiny copies. But again, it's true that for low CD4 numbers, there is a big a slight difference favoring the 3 drug. And actually, coming back to the switch from patients who are undetectable, actually, the SALSA study say that actually it worked very, very well in this setting. So again, look at the guidelines. The guidelines say that in patients with suppression, viral suppression below 50 copies, for the past 6 months, so for this sometime, the dual therapy strategy should be given, can be given, if there is no historical resistance, and also the issue of hepatitis B. The DHHS guidelines say that some two drug regimens are effective in maintaining biological control, provided their HIV is susceptible to most ARV drugs in the elected. So there should be no resistance to treatment. This is in terms of the precaution. And again, this is the same that the ISUSA guidelines say. Actually, a study, this study from Santoro, actually looking at, look, this is an observational retrospective study, so it doesn't mean too much, but in the univariate, what was a matter of concern was the duration of viral suppression prior to initiation of the infected tools. But when they did the multivariate, adjusting for all parameters, actually history of pre-existing mutation, the M184V, and the issue of viral suppression was not over 3.5 years, was not associated with virological rebound. That's a multivariate. So in a sense, they say that it doesn't matter if you have a history of M184V and you have a shorter duration of viral suppression. This is why, I mean, as a precaution, the guidance still continue to say, be sure that you have susceptible, that the virus is susceptible to the new drugs. And actually, post-hoc analysis of the SALSA trial shown before said that that using stringent criteria, looking at HIV RNA below 40 copies, the proportion of patients with archived resistance who responded at week 48 was similar when switched to the 350 versus 20. So, in a sense, let's say the rebound remained similar even in patients with archived and 184 mutations. So we could investigators here conclude that they support the use of dolutegravir previously as a switch strategy in patients with virological suppression, irrespective of the for how long the patient was suppressed and of the presence of resistance. But again, we need to be as clinicians, we always use precautionary attention. And personally, I would do let's say, look, I will have a look at the existing mutation. So, in summary, what the clinical practice suggests. So, does dolutegravir C match pre-drug ART in first line? In terms of durability, we looked at it's non-inferior throughout week 1.4. We have the data now. The blips, they looked at the blips, and there was no difference. There is no difference. There is also no difference in time to suppression when you start. So the time the suppression comes at the same time, mainly because the parent is very good in suppressing HIV. Again, the barrier to resistance is excellent. Actually, in the study, in the follow-up, 144 weeks, there's been just one case of dolutegravir resistance over 100 individuals involved. Safety, as I said before, better outcomes for the double combination with renal and and the issue of efficacy in high HIV RSV. Yes, the data that overall the systematic analysis say that it works also in patients with RNA baseline over 100,000, and the issue of the CD4 cell count below 200 is true, is seen mainly when we analyze the trial in the so-called FDA snapshot. And this is true also in other first line therapy, not only with two drugs. So let me say that overall, for first line, there are you can choose whatever you want, but if you want to choose for the reasons we explained at the beginning, two drugs instead of it's possible. Nobody said it's better other terms. Maybe better in terms of bone, kidney, maybe more costly. But any triple combination well tolerated is okay. If you look at the clinical practice, let's say guideline for switch, for using two drugs in the switch, then if you look at the long-term durability, yes, we have the data that say that it's durable. It's durable. When we switch, then the patient staying down for over 3 years. Now the data are quite with a long follow-up. They looked also at other sensitive viral markers, inflammation, etc. It didn't show up. Again, the blip frequency in the switch strategy, there was no difference. Again, very excellent barrier to resistance. So we know emerging of resistance when we use the intermittent. We see maybe if you look at double therapy, which is dolutegravir, which is another dual therapy, which is used. I can expand on that to make it shorter. And of course, there might be some small differences in terms of but both for dolutegravir and dolutegravir, we believe renal and bone markers did better. Again, because remember, as I said before, the problem was hepatitis, which may be something that we need to consider when you want to use a combination without an offer. So I thank you very much, and that's my mail. If you want to mail to me, and I hope to see you soon, maybe next year, in wherever you are, and wherever you will be, in which town in India. Thank you. Have a very good conference. Thank you again.
Thank you, Dr. Stino Vella, for explaining the advantages and limitations in using the two-drug. Well summarized the outcomes of Gemini 1, Gemini, and Diamond Cell trial. So these trials are clearly showed the effectiveness, potency, and durability of the two-drug regimes. They are not inferior to any other three-drug regime. They could decrease the long-term drug exposure and toxicity in H1N1 infection in AR in a patient. You explained clearly that the changes in their inner bone markers are favorable in Drug interaction factors. Thank you very much. I will hand on the co-chair.
Thank you very much. So bringing the new is really important. Addressing the people are really important. Catering their needs is our duty. So we are going to the next presentation. Can we recycle PDF for second line following treatment failure? Dr. Kruti Glada, over to you.
Good afternoon, everyone. It's actually an honor to be presenting the session where stalwarts are presenting, and an honor to be presenting in front of stalwarts who have literally grown up watching and still continue to be amazed with all their wisdom and their humility. So thank you to the scientific committee for letting me tell you an interesting story of tenofovir. And let's see where the story goes forward. So we, at the start of the ART era, we had AZT in the first line or the only line. And then we had tenofovir, and tenofovir was the second line. And then they switched places where tenofovir-based regimen became the first line and AZT became the second line. And now we are talking of tenofovir again coming to the second line. So I have no disclosures. The outline of our story, we'll see the background, introduce tenofovir and the other cast, the results from one retrospective study and 3 prospective studies. We'll see what those trials have to tell us, what are the implications for our public health programs, and is that the end of it, or are there other things, and what's the road ahead? So as we all know, TDF with either 3TC or FTC is the preferred first-line backbone. These are the latest WHO guidelines. And for those failing on this backbone regimen, AZT-based regimens are the recommended second line. And let's see a little bit of why is AZT the second line. So for a wild-type virus, obviously all drugs will be effective. And in those on tenofovir-based regimen and who fail on this first-line regimen, this is data from just 2 years back, but looking at data from 2009 to 16 from North India, where they looked at the drug-resistant mutations associated with NRTIs in those who were failing first line. And not surprising, the most common mutation that they saw was M184B at a good 63%, and K65R at 21%, and that's pretty similar across countries that followed this. So what happens when M184B mutation is there? So it affects the efficacy with lamivudine and emtricitabine, while the others are preserved. But we still continue to use 3TC in second line, despite knowing that there is one M184B, because it's well tolerated, because there is data to tell us that it retains significant antiviral activity even with that mutation. And importantly, that this mutation makes the virus hypersusceptible to zidovudine. What happens with K65R with tenofovir? So there is resistance to all of these drugs, but again, there is a hypersusceptibility to zidovudine. And when there is K65R and M184B together, zidovudine remains to be active. And that was the entire story why patients failing with TDF were moved to AZT. So this is data from one of the studies that we will see from HETI, where they saw pretty similar numbers of K65R and M184B. And based on the mutations, they thought that we believe that 93% of these patients will be sensitive to AZT and lesser to tenofovir. And therefore, those failing on TDF with first line was switched to AZT as part of the second line. One, for the infectious disease principle for many diseases, that we do not add one active drug to a failing regimen. So we already have M184B, which takes away 3TC to a certain extent. And then with K65R, we did not want to risk two drugs not being fully active, and therefore we changed to AZT. And knowing that with these mutations, AZT, like we saw, is still active in over 90% of the individuals. So it made it easier because now we could switch without even doing resistance testing. What happens then? So zidovudine brings with it adverse effects, a twice daily dosing, which means there is lesser adherence, and it disrupts the standardization of regimen and pill dispensing, especially at the public health program. So with all this, can we really recycle tenofovir again into second line, knowing all this? So this is one retrospective study which looked at individuals failing on TLE, which is our first line as well. And so individuals who failed TLE and were moved either to atazanavir-based regimen or loperamide-based regimen. And in these two arms, there were some who were switched to AZT, and there were some who were not switched. And they looked at the data of the switchers and the non-switchers, and also looked at what happened in the non-switcher group with lopinavir and atazanavir. And they found that switching from TDF to AZT was associated with lower rates of viral suppression than just recycling TDF. And that was when they saw the first viral load test, and when they classified it with those with better adherence, with not so good adherence, TDF still fared better. And when it came to adherence, not surprisingly, once daily regimen, the adherence at 12 months was better with TDF-based regimen. The other observations were that even in the ones who switched, who did not switch to AZT but continued to be in TDF, those who were on atazanavir did better, and that was because of the twice daily regimen with lopinavir. And there was better viral suppression with non-switchers, potentially due to twice daily regimen of the AZT and borderline. Coming to one of the most robust trials that studied this, which is the NADIA trial, we knew that there was data that described that boosted PIs are effective even with compromised NRTIs, but we did not know how dolutegravir would fare with a compromised NRTI regimen. So this was a multi-center non-inferiority RCT, looking at those failing on TLE or TEE and comparing them to how they did on dolutegravir versus darunavir and TDF versus zidovudine. And they wanted to answer two important questions. Is it optimal to give dolutegravir in second line when there is an extensive nucleoside resistance? And two, do we really need to switch people who are failing tenofovir to zidovudine? So this was a multi-center trial across 3 countries in Africa. They took individuals on TLE who were with viral loads more than 1,000, and they randomized them to either receive dolutegravir or boosted darunavir. And then they were further randomized to either switch their backbone to AZT3TC or to retain them on tenofovir and 3TC. What they found was at baseline, the K65R across all 4 groups was around 50%, and M184B was much higher than what we are seeing in our population, around 80%. And we've started to see those numbers now that we've been on TLE for that much time. At 96 weeks, the first result was that TDF is superior to AZT. When they looked at the intention to treat arm and looked at viral loads less than 400, looked at viral loads less than 1,050, and there was lesser HIV viral load rebound in those who retained tenofovir. What was worrisome is that there were dolutegravir associated mutations in both TDF and zidovudine arm, but definitely more in the zidovudine. But there was dolutegravir was non-inferior to darunavir. the other important thing was that all the mutations that they saw were with dolutegravir. There were no mutations whatsoever in the darunavir. So those were three very important results from the Nadia study. And when we see that when they studied the mutations, the ones that were in the zidovudine arm were high, and in the tenofovir were intermediate. Quickly to the two next studies, the Vicent trial, which was in Zambia, a randomized open-label non-inferiority trial. Let's ignore the arm A for now. We're only going to look at arm B, where they switched patients failing on TLE to either receive dolutegravir or two other PIs, which were boosted atazanavir or boosted lopinavir. And in this, they definitely had those with zidovudine and the ones that retained their backbone of tenofovir. And even in this study, they saw that those with tenofovir being retained fared better than those who were switched to zidovudine. And in this, you will see that those with zidovudine lopinavir had lesser levels of viral load suppression compared to those on atazanavir. And that was across both when we looked at HIV viral load less than 1,000 or less than 50 copies per mil. The last study that we are going to talk about is the ARTIST trial, which was a smaller study, a single-arm prospective study, which looked at patients, 60 patients with failing on TLE, and was switched to dolutegravir-based regimen. One interesting thing that they did was they gave an additional dose of dolutegravir for 2 weeks after the switch to overcome what they thought there could be some equivalence induction. In this trial as well, the proportion achieving viral load suppression was 85% when they looked at less than 50 copies per mil. And when they looked at less than 1,000 copies per mil, there was just one patient who was in that category. And even in that patient, there weren't any mutations. So it was because of non-adherence that they could confirm on drug level testing. So with this data, we know that tenofovir does work when we recycle it in the second line. And why is it that tenofovir still continues to be efficacious despite the resistance to both tenofovir and 3TC? And we know that from older data that there is a crippling effect that NRTI mutations have on viral fitness, resulting in some residual antiviral activity, even if those mutations are there. So I'm not sure if you can see this clearly, but for a wild type, the replicative capacity is around 100%. And when there is one other mutation, just one mutation, it brings it down to 68%. And they attribute this to K65R on M184B. And as the patient continues to be on this failing regimen, they will accumulate more mutations. And the replicative capacity, when it goes to 6 or 7 mutations, really comes down to less than half. The second important thing is that K65R and M184B mutation has some protective effect against the development of the key dolutegravir resistance mutation, R263K. So these two facts help us have more confidence in being able to recycle tenofovir in the second line. So what do these studies actually, what are the things that they're actually concluding from all these 4 trials? One, TDF is superior to AZT with respect to viral suppression in the second line. The other advantages are a reduced chance of viral rebound, increased CD4 count, possibly a reduced risk of higher and dolutegravir resistance. We still do not have enough data. That's only very little data from clinical trials, and better adherence with once daily dosing instead of twice daily dosing. Something that we did not expect, but what we saw was the advantage of darunavir, non-inferior to dolutegravir, in contrast to the other studies that we saw. The other studies that compared dolutegravir with either a boosted atazanavir or a boosted lopinavir, dolutegravir fared better. But when it was compared with darunavir, it was non-inferior. And the advantage might be that genetic barrier to resistance is higher with darunavir, especially when we are combining with NRTIs that have pre-existing drug regimens. So implications for public health program with this understanding that guidelines that recommend switching from TDF 3TC to AZT 3TC in the second line may need to be reconsidered with all this that we know. Use of TTG and darunavir with 2 NRTIs in the second line will produce durable pipe suppression, even when we know that there is a substantial NRTI resistance. And this can be delivered in places where we really cannot do robust viral load testing. It also encourages the universal switching from those stable on efavirenz to dolutegravir even without doing a viral load testing. And one important thing that Professor Clayton said was that probably the way to avoid dolutegravir resistance is to stop combining it with zidovudine in the second line, so that we prevent those high dolutegravir resistance. So it's a very encouraging and appealing thing for programs because that helps us maintain tenofovir, and that helps greater drug standardization. But a few things that we will have to remember and are overhead. When we switch these patients to tenofovir-based regimens in the second line, frequent viral load monitoring will be required, and we will require more population-level surveys because we did see those 3 mutations in a clinical trial. What it translates to when we really start doing it on a public health level, we really need to understand that. Darunavir merits an expanded role as the preferred protease inhibitor, probably more than dolutegravir. The costs are prohibitive currently, but once the cost factor is taken away, maybe darunavir will become the drug of choice for second line with the backbone. We still don't know what those resistance testing algorithms now mean with all this. How are we really predicting resistance, or what is it? So all that will change. Importantly, this data cannot be extrapolated to other NRTIs because the signature mutation K65R is believed to run this entire key thing that we saw in the clinical trials. And there was some discussion about PrEP yesterday, that PrEP users, if they get HIV, there might be drug resistance. And this might be an encouraging result for implementing PrEP with the evidence that even if there are some mutations, we can still use PLD as the regimen. So that's the end of my talk. And sometimes life brings you to a full circle, to a place you have been before, just to show how much we've grown and how much we've learned in that process of going around the full circle. Thank you so much, and thank you for patient listening.
Thank you very much, Dr. Putri Glanda, for this insight and to have analyzed well during the course of using many studies. Well done, and we will wait for the discussion at last. Thank you so much.
Coming to the third topic in this session, rapid start of antiretroviral therapy. The speaker is Anton Bojanai from London. Now, for your remembrance, yesterday evening, S.K. Guha in his talk on guidelines for advanced HIV disease briefly mentioned about rapid start of ART within 1 week in diagnostics advanced HIV. Today morning also, Dr. Pradeep Kumar discussed a little bit about the rapid. Now, Dr. Anton will elaborate, speak on this topic. Over to Dr.
Hello, I'm Anton Wozniak, and I'm going to talk about rapid start. Here's a bit about me. I'm a consultant physician at Chelsea Westminster Hospital and a professor at the London School. My disclosures. So there's a big controversy over same-day ART, or so-called rapid start. What is the readiness of the patient to start? Have we got time to counsel them? Have we got the clinic capacity? What about excluding TB and cryptococcal meningitis? What is the effect of it on long-term virological outcomes? Do we have to take into consideration transmitted resistance, hepatitis B? What about the cost? Lots of controversy, and I'm going to talk about those today. So what is actually the definition of rapid? Well, it's the same day or within a week. And I think WHO and the IAS, the USA, have said that that's the case. So either the first time you come to a clinic or the first time you're diagnosed or within a week is rapid start. And what's the pros and cons? Well, the pros are you get ART uptake, obviously, very quickly. Retention, that's the controversial item I'm going to speak more about later. Reducing transmission, looking at good outcomes from doing this,
And also the patient has some control over starting the therapy themselves on the same day. The cons, well, you have to do some baseline tests and you haven't got the results back from those. You need to make sure there's counseling, adherence, the clinic has capacity, but most of forefront, the patient has to be prepared to do it. Now, there is a model of same-day art in Asia, and this is from the Thailand art initiation hub. So it's a hub and spoke model. People are referred in, either newly diagnosed or re-engaged. On their first visit, they have a readiness assessment and counseling, they have blood collection and chest x-ray, they have a medical history and physical exam, and that's started on antiretrovirals. Then there's a follow-up visit where they're seen and notified about their lab results. That may not be physical, obviously. They can have a assessment of their side effects on art. And if everything's good, they can be prescribed for a further 2 months. And then they are referred out. So that's a hub-spoke model for initiating art rapidly. How well does it do? Well, you can see nearly 75% of people are started on the same day. And here's the breakdown with your MSM, transgender, or in the general HIV population. And most people you can see here within a week, so the 90% are started on antiretroviral therapy very few later on. So it's a model that seems to work very well in getting people on the treatment pretty quickly. What about the results? Well, in the same-day art program, they're nearly 4 times more likely to start antiretrovirals than in standard of care, you can see here in this graph, and are again over twice as likely to be virus suppressed out to a year, and you can see here the graphs there. So they have some good results in terms of starting people and getting them suppressed. What about retention? Well, here we are, retention and viral load suppression. You can see here very good retention rates, nearly 90%, and very good viral suppression, as I've showed. But actually, when you look at retention over 10 sites, there's no impact of the rapid start on retention. It's independent. Here are people who start on the same day, 95.6% retention. Here are people who started over 3 weeks, 95% retention. And here's people who start in various weeks in between. So there's not a link in the Thai data between when you start and if you get retained in care. Other not so good results that come out of South Africa. A large number of people, here's 13,000 people starting on the same day. And it's great in terms of reducing mortality, starting people same day art. But in terms, and maybe that's because a lot of people have very low CD4 counts when they start in South Africa. But in terms of active follow-up, you can see that it's less if you start on the same day, remaining in active follow-up. Loss to follow-up is greater, and transferred or moved out is greater. And it may be to do with the fact that it's a big rural country where people may get tested in the countryside, have to go to a clinic to start same-day art, and maybe they have to go somewhere else to have continued therapy because the place where they go to get same-day art may not be where they live. Anyway, there may be many reasons why this didn't work out as well as, say, in Thailand. And also the French have shown again that if you start art very quickly, it's still not associated with better retention in care. So here's something that says it's quite different. And this is from Taiwan, again, the Asian region. Here they had higher engagement in care at 12 months in the people that started within 7 days. So opposite to that, we've seen with the French, the South Africans, and with the Thais, and a lower risk of loss to follow-up. However, younger people under 30 were more likely to experience loss to follow-up and more likely to be diagnosed with an STI. So what about laboratory? What do you need? Well, this is debatable. It depends where you are and what you've got. Full blood count, creatinine, tests for hepatitis, pregnancy test, chest X-ray and gene expert tuberculosis, serum cryptococcal antigen, or maybe the urine test if you have that. Pre-treatment CD4, well, that may or may not be so relevant to do straight away. STI testing, obviously, if people come in with HIV, and a simple urinalysis. And there are other things that people do, but they're not immediately needed, and they may not be available, like resistance tests and RNA levels. Now, is it safe to start in the absence of baseline lab results? The Thais have got this very interesting data. Here's what happens in the green bars here. to people who start straight away, and you can see the abnormalities in creatinine, ALT, syphilis, etc., compared with their other groups they've started, and you can see that the actual abnormalities in these parameters, all the way from creatinine to chest X-ray, are very similar to the MSN and transgender group. The one thing that's quite different is the rates of syphilis, again similar to MSN and transgender, but very different to the general population. But if you do the labs and find that they're abnormal, you need a clear and preferred method for contacting the patient and make sure actually within 72 hours you can do the follow-up. So what about opportunistic infection screening? You don't want to start out immediately with someone with TB meningitis or cryptococcal meningitis. So you need some directed symptom screening. And here we are from South Africa. They really look very carefully for patients with TB symptoms. And they said this should always be, if anyone's got symptoms of TB, should be investigated before ART initiation in case of TB meningitis. And patients with headaches should also be have cryptococcal and TB meningitis in school. So is this an innovation in HIV treatment and care? Are we removing structural and other potential barriers to accessing HIV care? Well, we probably are. Here's a community perspective from Simon Collins in the UK. He says that ART can normalise HIV in periods of high stress, and that is certainly the case when we first diagnosed. Many patients see treatments as hope, and that also they want to get on treatment to get their viral load down. So U equals U to reduce any worry about transmission to partners. And in London, one of the main reasons for immediate ART is that patients come in and say, I want it. I've been diagnosed today. I want the treatment today. And actually, there's been very few exceptions to uptake of rapid ART in my setting. And obviously, it's a very patient-centered approach to care. But we need also to be realistic that we don't just offer this to patients we think might accept it, who might have transport, might have access to services that are close by, etc. We must make sure that vulnerable populations are also offered this rapid start if we're going to move along with it, and make sure that we have health equity approach. So what can you learn if you're going to start this? Well, this is keys for success. You have to embrace innovation. We have to have buy-in from everybody involved. We might have to restructure our clinic, have flexible scheduling to take account for increased time spent in the clinic. And we need a clear plan for the abnormal lab results. So it's a time for change if we're going to do rapid start. But what do the guidelines say? Can we follow guidelines with this? Well, WHO strongly recommend this. They say same day when feasible, and they think that use is lost to follow-up, which is controversial, as I've shown you. But there is a decreased time to viral suppression, and the mortality issue is important. The other big guidelines, DHHS, DACS, and ISUSA, all more or less say the same thing as WHO. The ISUSA actually say again, ideally within 7 days. Patients have to be ready, and of course, there's a lot of benefits that they point out in rapid start. But what about which drugs to use? So the guidelines all come down the same side, really. It's a high barrier to genetic resistance third agent, either a second generation integrated, entecavir, dolutegravir, or a boosted PI, darunavir, and to avoid NNRTIs, and also dual therapy and abacavir because of the HLA issue. So there we go. They really come down to say what we should use in rapid start. But what about the evidence? What does that show? Clinical trials and systematic reviews and meta-analyses. Well, if we look at the clinical trials, we've got 2 trials. Neither of them are placebo-controlled or controlled with any other regimen, one against another. This is a single-arm study starting within 24 hours using darunavir, cobicistat, FTC, and TAP, with a lot of analyses along the way. You can see here the sort of layouts, and the primary endpoints at 48 weeks. And what did they find? Well, they found that whether you had acute HIV or early HIV infection, then your undetectability of less than 50 was around 80%. And it was about 85 to 90% used less than 200 copies. So not a bad outcome actually at rapid start using a boosted PI. And if you dual therapy, what about that? Dolutegravir 3TC in rapid start? Well, it was interesting that the number of patients who had virological success by ITT missing equals failure was similar, which is interesting. And when we look at here, the FDA snapshot is around 75, 76%. Which again is not too bad a figure in the end for people who are rapidly starting. But is that good enough? And what are the problems? Well, one of the problems with dual therapy is this: if you've got hepatitis B, then you don't want to be on 3TC alone. And all of these patients who have B switched over to triple therapy. And if you've got a baseline 184B, then you're only going to be on dolutegravir alone, basically, and you should be switched. And there was pregnancy here and a couple of other problems that went on. So I'm not sure about dual therapy. It looks quite good, but I don't see why we shouldn't start with triple. And maybe once the results are back and everything's good, you could go down to dual if you want. What about meta-analysis and systematic analysis? This is one done by WHO, and they have said the likelihood of loss to follow-up and death is decreased. Well, the loss to follow-up is a bit patchy, as I've shown you so far. As the heart retention in care, but the viral suppression true. And when we look at further the Cochrane analysis, mortality is reduced by rapid start. You can see that here. And also viral suppression at 12 months, again, favors rapid R. So I think these are two of the big reasons: reducing death rate and getting viral suppression down. Of course, that feeds into U equals U. So finally, starting ART on the day of diagnosis or linkage, even before the lab results are obtained, is safe and well tolerated. And I think that the guidelines have pushed this out to 1 week rather than the day of diagnosis. Immediate ART, so within a week, leads to earlier viral suppression and may increase retention in care, but that's debatable. But the sustained viral suppression and the mortality issue is very important. We do need trials, though. We've got no real major trials of one therapy versus another, or waiting, starting people immediately and waiting for 1 month stay, et cetera, in terms of doing this. We've got very little operational research or cost-benefit analyses for this. So if you're going to use drugs, then you need a high barrier to resistant third agent, either second generation integrate or darunavir with cobicistat or ritonavir. But again, we've got limited data. We've also got limited data in people who say they failed PrEP. And rapid ART, yes, you need to embrace it. You need to change the way you're dealing with things, but also we need to do research. And with that, I'd like to thank you very much.
Thank you very much, Dr. Anton, for clearly explaining the various pros and cons of rapid start in the same day or within 1 week of diagnosis of HIV. You described very well how to keep the patient in retention care and how to maintain the viral. And we discussed elaborately various studies. Thank you.
Thank you very much. The last presentation in this session is long-acting ARVs for treatment. Dr. Constance Benston from USA. Over to you, Dr. Constance.
Good afternoon. I'm Constance Benson from the Division of Infectious Diseases and Global Public Health at the University of California, San Diego, and it's my pleasure to talk with you today on long-acting injectable antiretroviral drugs for treatment of HIV. I'd like to thank the organizers for asking me to do this talk, and I'm sorry I can't be with you in person. So let's start right in with the outline for my talk. The rationale for developing long-acting injectable antiretroviral drugs will be the first topic of discussion. I'll follow this by reviewing recent data from clinical trials focused on treatment. Prevention with long-acting antiretrovirals will be discussed by other speakers. I'll be focusing on 3 different classes of drugs that are either recently approved or in development as long-acting antiretroviral drugs, and these include cabotegravir, an integrase strand transfer inhibitor, plus rilpivirine, an NNRTI, lenacapavir, which is a first-in-class capsid inhibitor, and broadly neutralizing antibodies. And then I'll finish by concluding remarks about long-acting injectable antiretrovirals and how to use these in clinical practice. So let's start with the rationale for development of long-acting antiretroviral drugs. And this really relates to the challenges with adherence to conventional antiretroviral drugs for some individuals. And the major challenges that have been discussed in a number of settings include stigma, the lack of desire on the part of individuals with HIV, either to be constantly reminded of their disease themselves or to be in a position where others are aware of their HIV infection because they're taking pills. There's also the issue of pill fatigue, difficulties with swallowing pills, and other complications associated with pill-taking behavior, the inconvenience or lifestyle interference of having to carry pills around with you and take them every day, interfering with work, with travel, with other activities of daily living. And then lastly, tolerability and concurrent comorbidities that might interfere with adherence, including drug-drug interactions with agents used for treatment of concurrent comorbidities. The Carlos trial, which is a 3-year prospective cohort study in Germany of people living with HIV that was presented last summer at the International AIDS Conference, also highlights some of these points. And looking at surveys that were performed for people living with HIV who switched from daily oral ART to long-acting ART, recapitulates these reasons for developing long-acting antiretroviral drugs. Many of these individuals indicated that they were interested in treatment options that were more convenient. They were tired of taking medications every day. They were worried about forgetting their medications, worried about people finding out that they had HIV because of their pills, tired of being reminded of their HIV status every day, and having difficulty with the pills themselves. So I think these are common themes that make the use of long-acting antiretroviral drugs attractive for many individuals. So I'm going to turn now to injectable cabotegravir and rilpivirine, the first of the long-acting injectable agents to be approved for use in clinical practice. I can't review all of the clinical trials that have been done with these agents, but I just want to touch on summarizing data from 2 of these. The Atlas 2M trial was performed in virally suppressed individuals on antiretroviral therapy who were enrolled and randomized 1-to-1 to either every 4-week injections of cabotegravir and rilpivirine or every 8-week injections. And looking at the week 96 outcomes, you can see that the viral responses in terms of both virologic success and confirmed virologic failure were equal in both of these treatment arms. And when you looked at the adjusted treatment differences, the differences failed to cross the non-inferiority margin, indicating that both the 4-week and 8-week injections were comparable. Confirmed virologic failure did appear to occur in slightly larger numbers in the Q8-week arm, as did resistance-associated mutations to both rilpivirine or integrase inhibitors, but these did not achieve statistical significance and were comparable between the 2 arms. Injection site reactions were the most common adverse events observed. Most of these were grade 1 or 2, resolved in a median of 3 days, and less than 2% of individuals had to stop therapy because of an injection site reaction. The FLAIR study likewise looked at the use of cabotegravir and rilpivirine in long-acting injectable regimen and evaluated this in comparison to continuation of dolutegravir, abacavir, and 3-TC for maintenance of suppression. People enrolled in this trial were on dolutegravir, abacavir, and 3-TC with full suppression of viral load prior to enrollment. They were randomized to either continue with dolutegravir, bacavir, and 3TC, or to switch to cabotegravir and rilpivirine injections. Again, these just summarize the data and not to go through every detail of the study, but at week 48 and week 96, you can see that the virologic success rate was comparable between the two arms, as was the virologic non-response rate. And in the adjusted treatment difference graphics, you can see that in neither instance did treatment difference cross the non-inferiority margins, indicating that for the primary endpoint and key secondary endpoints, the cabotegravir and rilpivirine long-acting injectable agent was comparable to maintaining dolutegravir, bacavir, and 3TC. Confirmed virologic failure was rare. Resistance mutations occurred in a very small number of individuals in both treatment arms. In looking at a post-hoc analysis of the phase 3 data from both of these clinical trials, and including also the initial ATLAS trial, the factors associated with increased risk of confirmed virologic failure while taking long-acting cabotegravir and rilpivirine were listed here. Rilpivirine resistance-associated mutations at baseline, post-hoc or week 8 rilpivirine trough concentrations that were above the threshold necessary for suppression of viral load, a baseline HIV-1 subtype of A6 or A1, and a BMI of greater than or equal to 30 kilograms per meter squared at baseline. And this latter was a reflection of the suitability of reaching an intramuscular depot with the injection in people with very large BMI. Q8-week dosing, interestingly, was not a risk factor for failure of treatment with long-acting cabotegravir and rilpivirine. And so these data, I think, cement the findings from all of the trials looking at these agents in combination. There were some new data on long-acting cabotegravir and rilpivirine that were presented at Quota this year, and I'll just highlight one of these studies. And this is the SOLAR trial, similar to a previous study that was done. This study was a phase 3B randomized, and patients were randomized in a 2-to-1 ratio of cabotegravir, rilpivirine versus continuation of bictegravir, FTC, and TAF in this instance. People who were randomized in the study had to be receiving bictegravir, FTC, and TAF, and fully suppressed with less than 50 copies for at least 6 months prior to and at screening. Patients were then randomized to receive either continuing bictegravir, FTC, and TAF, or switching to first oral cabotegravir and rilpivirine for a lead-in phase of 1 month, followed by the injectable every 8-week long-acting cabotegravir and rilpivirine, or a group of patients were randomized to just directly go to injectable cabotegravir and rilpivirine. The primary endpoint of this trial was at 12 months and evaluated the proportion of patients with plasma HIV RNA of less than 50 copies per ml. Secondary endpoints are listed here. The groups were comparable at baseline with a median age of 37, about is 17% female, 20% Black, and BMI was a median of 26 in the study. The primary results are indicated here and show you the virologic outcomes at month 12 for the modified intent to treat analysis. And you can see by the purple bar, which represents the bictegravir oral therapy arm, and the green bar, which represents cabotegravir rilpivirine
adverse event rates were quite low. Injection site reactions were the most common adverse events in the long-acting arm again. Most were grade 2, grade 1 or 2, resolved within a median of 3 days, and fewer than 3% of individuals stopped their therapy because of an injection site reaction.
Interestingly, the findings from the primary results showed that treatment satisfaction actually favored the long-acting cabotegravir rilpivirine arm, as did treatment preference. And as you can see with the green bars here, 4 more patients had improvement in their treatment satisfaction on the cabotegravir rilpivirine arm, and overwhelmingly treatment preference favored cabotegravir and rilpivirine. So these recent findings from CROI this year recapitulate the findings from the Atlas, Atlas 2M, Blair trials, and other studies of this agent, and further cement this as an acceptable regimen for use in individuals with desire to switch to long-acting treatment. The SOLAR trial also looked in another portion of the study presented at CROI and changes from baseline to month 12 in weight and a variety of metabolic parameters. And although you can see there are a number of different parameters looked at in the trial, in looking at the directionality of changes from baseline to month 12, there were no clinically important changes in weight or any of the metabolic parameters that were measured, and none of these were statistically significant. So indicating further that cabotegravir and rilpivirine was similar to bictegravir, FTC, and TAF in terms of overall weight and metabolic outcomes. FDA approval in the US has indicated that both once monthly and every 2-month dosing is acceptable, and that an oral lead-in phase is optional. And the FDA indication is for individuals who are on a complete regimen for HIV infection that is fully suppressive and wish to switch, and should switch when they are virologically suppressed on a stable ART regimen and have no history of treatment failure or a known or suspected resistance to either of these 2 agents. So let's turn to the next recently approved long-acting injectable drug, at least approved in the US, is lenacapavir. And I'm only again going to talk about treatment trials in this instance. As you all recall from previous ASICON conferences, lenacapavir has been in development for some time. It's a novel first-in-class capsid inhibitor that has a broad range of activity against HIV-1 isolates, including those resistant to currently available drug classes. And it acts by modulating the stability or transport of capsid complexes and inhibits multiple processes necessary for viral replication. There are 2 major trials that have led to the recent approval of lenacapavir for use in treatment. The first of these is the Calibrate trial, which was a phase 2b study done in treatment-naive people with HIV infection, looking at lenacapavir in both an oral and a subcutaneous injectable formulation. This study enrolled treatment-naive individuals with detectable viral load and a CD4 cell count of greater than or equal to 200 cells per microliter. They were randomized in open label fashion to one of 4 different treatment groups. The control group in this study was oral bictegravir, FTC, and TAF. Treatment group 1 was lenacapavir given subcutaneously every 6 weeks in combination with oral FTC and TAF. Treatment group 2, same background regimen. Treatment group 3, oral lenacapavir given with FTC and TAF orally. And then for treatment groups 1 and 2 at week 28, patients had the FTC discontinued in group 1 and continued with TAF alone in combination with sub-Q lenacapavir every 6 months. And in group 2, bictegravir given orally alone in combination with lenacapavir sub-Q every 6 months.
So a somewhat complicated study design, but as you can see from the week 54 virologic results, which were presented at last year's CROI, the virologic success rate of HIV RNA suppressed to less than 50 copies was comparable across all 4 treatment arms. And in looking at the subcutaneous groups of lenacapavir, 88% achieved and maintained virologic suppression after 1 year of treatment. Virologic failure rates were also comparable, and only 2 patients developed lenacapavir resistance. And as outlined here, both were resuppressed on 2 NRTIs and another oral integrase inhibitor at the time of virologic failure, and 3 patients had treatment-limiting injection site reactions. The Calibrate study data were updated at this year's CROI in an abstract presented as a poster and looked at the outcomes through week 80, both by efficacy in terms of viral load less than 50 copies and efficacy overall in secondary endpoints of virologic failure and virologic data not available. And as you can see, most of these bars were relatively equal in terms of the week 28, week 54, and week 80 results, particularly for the subcutaneous lenacapavir given every 6 months. And these results were comparable to the continuation of bictegravir, FTC, and TAF. In ART naive people with HIV, subcutaneous lenacapavir with TAF or bictegravir and oral lenacapavir with FTC and TAF maintained high rates of viral suppression through week 80. Lenacapavir was well tolerated, and discontinuations due to adverse events were infrequent. BMI and weight gain was modest and similar across all treatment groups, and only 3 patients developed treatment-emergent lenacapavir resistance through week 80. The other major study of lenacapavir was done in people who were failing therapy and had multi-drug resistant HIV. In the Capella trial, key eligibility criteria were detectable viral loads greater than 400 copies per ml, resistance to at least 2 agents from 3 of 4 main ARV classes, and the availability of less than or equal to 2 fully active agents for use in optimized background therapy. A somewhat complicated randomization scheme was used here, in which the randomized cohort was rescreened pre-randomization. And if at the second screening they had a decline in their viral load to less than 400 copies or greater than half a log, they went into a non-randomized open label cohort, and the remaining individuals were randomized in the double-blind cohort. In the double-blinded randomization, patients were randomized 2-to-1 to receive 14 days of oral lenacapavir while continuing their failing regimen, or placebo while continuing their failing regimen. The non-randomized cohort went on to receive oral lenacapavir and optimized background therapy. At the end of the 14 days of functional monotherapy, maintenance phase of the study included lenacapavir subcutaneously every 6 months for 52 weeks, plus optimized background therapy. Those who had been originally randomized to placebo had a 14-day lead-in with oral lenacapavir, and then went on also to sub-Q lenacapavir plus optimized background therapy. And in the non-randomized cohort, who had already gone through an oral lead-in phase for 14 days, went directly on to lenacapavir and optimized background therapy. So these are the data of the Capella trial at week 52. This was presented at ID week, and again in an abstract at CROI 2023 this year. And the week 52 efficacy in both the randomized and non-randomized cohorts are indicated here, with comparable virologic suppression to less than 50 copies and less than 200 copies, comparable levels of virologic failure. And in both cohorts, this virologic response did not depend on the number of fully active agents in optimized background therapy. You can see that the proportion with less than 50 copies was similar regardless of the number of fully active agents. And CROI this past month. The efficacy of lenacapavir in combination with optimized background therapy was also shown to be consistent across diverse demographic groups, baseline characteristics, and optimized background treatment. And 8 of the 72 patients had lenacapavir treatment emergent resistance associated mutations. Let me go on now to talk about broadly neutralizing antibodies and where they may fit in long-acting antiretroviral therapy. Broadly neutralizing antibodies in general have been in development for some time. They are in development for 2 different approaches. One, to treatment as a long-acting antiretroviral, and secondly, because of their potential to directly eliminate infected cells, they are being evaluated in strategies to reduce the reservoir in cure of HIV strategy testing. Other characteristics of broadly neutralizing antibodies, they're generally safe. They've been engineered to have long half-lives when given by either sub-Q or intravenous infusions. They have antiviral activity that suppresses viremia, but they do also have the Achilles heel of selection for resistance, especially with monotherapy. And they have been shown in some instances to boost existing immune responses. So they're attractive for long-acting antiretroviral therapy. Ones in development are active at a variety of different membrane interfaces, including the CD4 binding site, the B3 glycan patch, the GP120 or GP21 interface, the B1 or B2 interface of the viral membrane, and a host of these are in development or have been tested in phase 1 and 2 clinical trials. I'm only going to highlight one of these here, the Banner trial, evaluating BH381-0109, now referred to as N6LS. And the Banner trial was presented this year at the Glasgow conference and looked at this novel broadly neutralizing antibody that targets the CD4 binding site of HIV-1 envelope protein. In a small study, phase 1-2 study, adults who had detectable viral loads, CD4 counts of greater than 250 and were naive to treatment, were randomized to receive functional monotherapy with a single infusion of the bNAb in either a low dose of 4 milligrams per kilogram IV or a high dose of 40 milligrams per kilogram given IV. And through day 11 through 84, then went on to receive dolutegravir and 3TC out through week 48. Primary endpoint was plasma HIV-1 RNA, maximum change from baseline during monotherapy, and safety. And I won't go through all of the details of safety and virologic response, but suffice it to say that the IV infusions were highly effective in suppressing viremia with viral naters of greater than 2 log reduction in the effective monotherapy period of observation. And the higher dose was associated with greater viral suppression and longer median time to viral reground in this study. And the infusion was safe and well tolerated. Another study, which is perhaps of greater interest, was presented at CROI this year. And this combined 2 different broadly neutralizing antibodies, teropivimab or TAB and zinlervimab or ZAB, together with lenacapavir in a randomized blinded phase 1b study. The goal of this study was to assess safety and efficacy of this long-acting 3-drug regimen in 2 different doses of zinlervimab. And the study was originally designed to have multiple dosing over a 1-year period of time with lenacapavir given twice, as well as 2 infusions of TAB and ZAB. However, lenacapavir was put on hold for a short period of time due to storage file compatibility issues with lenacapavir, and therefore the study design was amended. In group 1, patients were randomized to receive lenacapavir plus TAB and ZAB at the low dose, or lenacapavir in group 2 plus TAB and ZAB at a higher dose. The lenacapavir dosing in this study was 2 oral doses at day 1 and 2, and a subcutaneous dose on day 1, and TAB and ZAB were both given by infusion on day 1. HIV RNA was measured at least every 4 weeks with a primary endpoint at week 26. And the virologic outcomes at week 26 are indicated here. You can see that they were equal across the 2 arms. Again, reminding you this was a small study. 9 of 10 patients in each arm were fully suppressed to less than 50 copies at week 26 in both arms, and 18 out of the 20 maintains viral suppression. 1 participant withdrew at week 12, but had a HIV RNA of less than 50 copies at the time of withdrawing, and 1 participant had confirmed virologic rebound at week 16, but resuppressed on baseline oral ART after virologic failure. Interestingly, looking at the pharmacokinetics, therapeutic concentrations and serum levels were maintained for both TAB and both doses of ZAB, as well as lenacapavir throughout the 26 weeks of follow-up. And the levels that were achieved and maintained were well above the therapeutic concentrations that were necessary to suppress virus for each of these 3 drugs. So interesting findings for another combination of long-acting antiretrovirals and antiretroviral drugs. So in conclusion, I'd just like to state that long-acting antiretroviral drugs are rapidly emerging as treatment options in clinical practice. Optimal patient candidates for long-acting antiretroviral treatment are individuals who have been suppressed on antiretroviral therapy for 3 to 6 months, have an oral lead-in is optional in this instance. Contraindications to switching to long-acting oral drugs include prior resistance to either the agents used in the long-acting drug regimen, or chronic hepatitis B infection, or no vaccination for hepatitis B. And the reason for this, of course, is that none of these agents are active against hepatitis B. And lastly, several studies at CROI this year demonstrated the need for suitable clinic infrastructure in order for patients to be successful in maintaining viral suppression on their long-acting injectable drugs. And support for injections and their cost, availability of space, follow-up of patients, wraparound of social services, particularly for individuals who are challenged in terms of adherence, are important factors in helping individuals maintain suppression on long-acting antiretrovirals for treatment. I want to thank you for your attention, and I'll turn you back to our hosts here.
I would like to just inform that all 3 stalwarts are online. They are in 3 different countries. One is in the USA, one is in Brazil, one is in Italy. But 2 of them are lifetime achievement award winners of organization. 2 of them are former presidents of IS. All and this hour, because Anton is watching in Brazil, it's 3:30, 4 o'clock there, and Stefano is there. So I think those we have some questions for them. Please ask.
Question from the field.
Ask question.
Because this belongs to our Indian population. Hello. We have changed our TLE program to the TLD in our programs, India. Does it have scientific base or just a convenience of the programs? Question. there?
Hello.
Hello, Dr. On?
Hello. Can you see me?
Hello. Oh,
Hi.
hello.
Good morning.
Yeah, good morning. My question is that there is change of TLE program, TLE to TLD in Indian government programs. Has it a scientific base or it is just convenience of the program? TLE to
I think
TLD.
yeah, it's got of course it's got a scientific base. There were studies to show that dolutegravir was superior to efavirenz. That's the first thing that happened. The second thing was that the side effect profile, which drove those results, became very highlighted against efavirenz because of its neuropsychiatric side effects. And that's why, and especially the tendency towards an association with suicide in those people who had previous depression. So there's a lot of data against efavirenz in terms of its comparison with dolutegravir. Dolutegravir has been shown to be very safe. The other thing that's really helped drive the programs is resistance. As you know, we had a lot of NNRTI resistance in the background, and using efavirenz was a challenge in those patients. And also, if you were poorly adherent to efavirenz, you develop resistance very quickly. With TLD, the resistance issue was very much minimized, and very few people have had virological failure. It's handfuls on TLD as a combination pill. So there were lots of things driving that switch away from TLE to TLD.
Thank you very much.
Hello, this is a question to Dr. Constance Benson. And hi, Connie, this is Savita Power. I wanted to ask you, in the long-acting injectables, I believe you said that you have to see them every 1 to 2 months for follow-up. Isn't that a hindrance in comparison to just regular old ART? Oh.
Do you want me to answer that question? Yeah, it's a challenge. It's a challenge because what's happened is that people who have been coming every 6 months have to come every 2 months. There is a move to try and develop formulations which patients can give themselves, but if you're giving 2 monthly injections, you need to have a clinic set up in which those can be done, and patients must realize that they're actually coming 6 times a year instead of twice a year. Obviously, this isn't going to be a job for the physician. It's going to be a job for the nurses most of the time, but their workload will have to change. I'm not saying it's going to increase massively, but it'll have to change. And also in your clinic, you'll have to have facility to store the drug, so it needs to be kept in the fridge. And also you'll have to have availability of people in your clinics who are skilled in giving intramuscular injections. Now, at the moment, usually they're given by nurses. There are some places where they can be given by pharmacists, and there's been some plans to think about giving these injections in the community by nurses and pharmacists. But most of us at present are giving them in the clinics. So you're quite right. You have to adapt the service. You have to change the way you work, and the patients will need to come in regularly. Having said all that, most of the patients that we've seen who want injections are fine. They're motivated to do that. But it is a different way of looking at antiretrovirals, yes.
Yeah, I guess there would be a select group of patients who would want it like this versus just oral medication, so that they could come once every 6 months. And you could choose, people who are not adherent to therapy and things like that to really make it more feasible.
Yeah, I think that injectables have highlighted an equity issue. For example, do we only offer them to people who really want them, who really are very adherent in the past? I mean, the data that Connie Benson mentioned from Monica Gandhi showed she gave them to people who are viremic, who are homeless, although they had a big package of care, social care, okay, those people. And your situation in India may be very different to that in the United States. But we have to be very careful that we don't have injectables for, say the elite, and we don't offer them to those that may benefit from them. But we have a preconception that they won't take them, they won't come, they won't do this, because sometimes our ideas of what patients will and won't do are quite different from patients. So, but there's lots of operational research ongoing, looking at these things, and I hope it will be more clear about how we're going to use these drugs from an operational point of view in the next year or so.
This is Raj Pava. I have a question for any of the speakers, Stefano or you. You have a HIV genomic diversity. You have a HIV virus subtype, A, B, C, and you have a recombinant virus. What do you suggest the clinical care of the subtype viruses and infection in different parts of the world?
Is Stefano there? Does he want to answer that? If not, I'll try. Okay, so do subtypes matter? It's a long lecture actually, but I'll try and just summarize some of it. Some people were worried about K65R and subtype C, and that you had more chance of developing a K65R in subtype C. We haven't seen really a lot of that happening. I mean, it's been more experimental data than actual data that's come out of clinical trials. But the one place where subtypes appear to matter quite a lot is with injectables. And if you look at subtype A and look at the subtypes A1 and A6, they are risk factors for virological failure on injectables. So in parts of the world where subtype A1 and A6 are common, and it's in parts of Africa and at the moment also around Ukraine, Russia, Poland, and migrants coming into Poland from Ukraine, those are the areas where we seem to see a lot of A1, A6. So the issue is, if we're going to use injectables, should we do these subtypes? And we do, but it might be a slight issue in terms of rolling out injectable treatment everywhere, where there might be a high risk of having an A1, A6 subtype epidemiologically, and that's a question that's not been addressed. But in other places where A1, A6 is rare, from a public health point of view, it's probably fine to roll out injectables without having a real big concern about the subtype. But that's still, from my point of view, a theory rather than a proven fact.
Any more questions? So thank you very much, all the speakers who has taken their time in the middle of the night and answering our questions. Thank you very much.
Thank you everyone. Now I will request our chair to felicitate Dr. Trupti. Yes, rest of.
Should have some virtual mementos.
Yeah, I think we should have some virtual mementos for.
And Dr. Kumar, you can do.
And Dr. Kumar, you can do. Yesterday you were doing bouquet virtually. So
I will request Dr. Guha. Dr. Guha,
I will request Dr. Guha. Dr. Guha, just felicitate our chairs.
And after that, we will break for lunch.
And after that, we will break for lunch.
For, I think, half an hour.
For, I think, half an hour.
Have your lunch
Just
and then we will see you.
have your lunch
here.
and then we will see you here.